All right. Welcome back. Welcome back for the break. Glad that some of you are still here with us. We're coming close to the end. Right now, we'd like to introduce a couple of our sponsors, get a few words from them. Sonja Thompson, a senior manager in the U.S. field market development, focusing on pelvic health at Medtronic, also followed by Nishith, the director of federal relations with American Cancer Society Cancer Action Network. So I'm sure they're going to have some great things to say. Sonja?
Well, hello and good afternoon. What a great conference it's been thus far, right?
Yeah.
I am thrilled to be here with all of you beautiful people that are left with us to highlight some of the amazing work that Medtronic is doing to advance health equity and improve access to care in the Black community and beyond. So I'd like to see a show of hands. Who has ever heard of Medtronic prior to this conference? Okay, great. Now, show of hands, who of you knows someone that has had a device or therapy that belongs to Medtronic? Okay, still quite a few. Okay, great. Medtronic, for those that do not know, we are the largest medical device company in the world with over 49,000 patents in our portfolio. Our technologies reimagine the treatment of over 70 health conditions in over 150 countries worldwide. From pacemakers to insulin pumps, dialysis catheters, to the thousands of ventilators that we donated during the pandemic, Medtronic transforms literally 2 lives every second of every hour of every day. See if these advance. This big green button in the middle, I think, maybe. There we go. There are 6 very powerful words that we work and live by at Medtronic that drive our company mission: alleviate pain, restore health, and extend life. This is our never-ending North Star that not only inspires and guides us, but it really does define who we are. But notice that this mission doesn't say restore health to just some, right? It doesn't extend life for just the select few. Our CEO, Jeff Martha, I think he said it best: the global crisis of health inequity will only be solved by accelerating access to healthcare technologies that put people with access to technologies that put people first. So we know we have a crisis here in the US, right? Every day, more and more research continues to demonstrate the significant levels of health disparities in our country. Black women are dying at 4 times the rate of white women. Black adults, 60% more likely than non-Hispanic white adults to be diagnosed with diabetes. I mean, the list we know goes on and on. So we looked at these disparity stats, but we also wanted to understand what hospitals may be doing to combat these issues. I found that the American Hospital Association surveyed 600 hospital executives to better understand the state of health equity initiatives across the US. And I found that although 96% of them indicate reducing disparities is a priority, that over half of them have yet to initiate a health equity program. This is a problem. So at Medtronic, we know we play a critical role in the health equity framework, representing technology and innovation care for over, again, 70 different health conditions. And I'd like to highlight some of the great work we've done thus far to support our patients, providers, and business partners. We've adopted a framework, a strategic framework that drives to show up the right way consistently for our patients through a uniform care pathway development. This is something that we strive to do in pretty much every therapy that we support. First, we identify the problem or the barrier in care. Then we engage the clinicians or patients to understand the needs in order to improve on that care, right? Next, we intervene by developing a strategy to overcome that barrier. We then execute the strategy. And then lastly, we measure the outcomes so we can learn from it. In all care pathway development, which is what I've done my entire career at Medtronic, is I know that measurement is key. If we don't data collect and measure the outcomes, we won't learn what optimal care pathway it looks like for our patients. So this is very important to the work that we do. In adopting this strategy, I'll be honest, we realized that we had some internal barriers of our own when it came to developing marketing strategies and marketing campaigns that educate patients and clinicians in an equitable way. So we turned the strategic framework inward and we identified opportunities to develop our own internal resources that would help us reduce bias when we're developing our marketing strategies. So early 2022, I was part of a small work stream within Medtronic where we created an internal resource guide that we filled with best practices on how to market more effectively to people of color, how to develop patient education that is relatable, that looks like us, that sounds like us, right? This was very important. So while we were working on this, we were also working on health equity on the ground level, opening our first US-based Medtronic lab in partnership with the Cherry Hill, New Jersey Free Clinic. These labs that we've developed across the world are dedicated to creating technology-powered healthcare solutions to accelerate patient access for disadvantaged communities like Camden County, New Jersey. With 10 other Medtronic labs out there already thriving in countries like Kenya, Rwanda, Ghana, Tanzania. We've trained over 3,500 health workers and completed over 1 million healthcare screenings. It's been some amazing work we've been doing. So now it's time to bring that work home, right, and take care of our community, starting with Cherry Hill. So I'm really excited about that program and that lab, and I look forward to many more to come. So now, Medtronic, we've done all this work on ourselves, right? We've developed this framework. We've partnered with our communities. We've developed internal tools to reduce bias in our patient education materials. And so as a company, we reflected and we asked ourselves, okay, so now what else can we do? How else can we help? And that's when we realized that these hospital partners of ours that, again, are talking about initiating these health equity programs, but haven't quite got there yet, right? How can we support them? So hot off the press to you all, we actually have not even put out our press release on this yet because it was just approved last week. You're the first to hear about this. It's Cardiovascular Health Equity Resource Guide. And so this is an external facing resource guide for our hospital partners, clinical society partners, one-of-a-kind resource that really highlights evidence-based solutions and best practices to support conversations between hospital leaders, clinicians, our Medtronic teams, and all of our different therapies, and then obviously other key stakeholders that are interested in advancing health equity. In this tool, we have tons of examples, but I wanted to highlight a few today, and I pulled out a couple that are actually sponsors here of this conference as well. So one of the examples that we leverage in this guide as we support efforts to drive community awareness is the American Heart Association's Empowered to Serve initiative. This program offers lessons that motivate communication on blood pressure, education on heart, stroke, and much more. Another great example is the CDC's Million Hearts campaign. This is where they drive community awareness amongst Black adults on cardiovascular health. And then another great example from one of your title sponsor, the Robert Wood Johnson Foundation, is their messaging guide on the social determinants of health. We are leveraging this also as a company. This toolkit has some effective best practices on how to communicate more effectively with key stakeholders in order to move them to action on some important issues. Again, these are just a few of the best practices in our resource guide that we're leveraging and sharing out to the community, to healthcare administrators, et cetera. And we're leveraging this to be able to send some examples to show the level of education that Medtronic has to health equity. Really continuing these initiatives with additional focuses on clinical research diversity, vendor and supplier diversity within Medtronic, as well as health equity framework I shared on developing optimal care pathways. Our goal continues to be to promote better patient outcomes for all, and Medtronic is steadfast in our commitment to do just that. So I truly appreciate the time. If you want to learn more about the work that Medtronic is doing, you can always go to medtronic.com/ourimpact. And obviously, I'll be here the rest of the conference as well if you have any questions. Thank you for your time.
Good afternoon. My name is Nishith Pandya, and I serve as Director of Federal Relations for the American Cancer Society Cancer Action Network, or ACS-CAN, which serves as the advocacy arm of the American Cancer Society. Thank you all for being here today, and thank you to the Center for Black Health and Equity for putting on such an enriching, empowering, and energizing conference. As everyone in this room is acutely aware, health disparities are very real in our country. They're particularly real for the Black community and other communities of color. This situation has been so long-term and so widespread, there's even an adage. When white America gets a cold, Black America gets pneumonia. The recent COVID-19 pandemic was a stark reminder that not only do health disparities exist, but they have real-world life or death consequences. Speaking from a cancer perspective, the facts are clear. Black people have a higher cancer burden and face greater obstacles to cancer prevention, detection, treatment, and survival. Cancer causes about 20% of deaths among Black people in the US. In fact, Black people have the highest death rate and the shortest survival rate of any racial or ethnic group for most cancers in the US. And the underlying source of these disparities is structural racism, which impacts all areas of life, including limited access to quality healthcare, education, food, housing, and I said healthcare already. Sorry. While we know that cancer impacts everyone, we also know it does not impact everyone equally. That is why ACS-CAN and our volunteers are fighting for public policies at all levels of government and across the country that reduce cancer-related disparities and improve health outcomes for everyone, regardless of race, ethnicity, gender identity, sexual orientation, ability, income, or zip code. In that regard, I would like to spend some time today focusing on 4 of our key priority areas: access to healthcare, cancer research, early detection, and commercial tobacco control. These are all areas where there is scientific evidence of health disparities that ACS-CAN is working to overcome. First, in terms of access to healthcare, we know that in the 10 states that have not expanded Medicaid to cover all people with certain limited incomes, close to 2 million people do not have affordable health insurance options, including 1 in 4 Black residents. Black and Hispanic people are more likely to be uninsured compared to their white counterparts, and patient navigators can guide patients through the complicated processes, reduce financial, social, and cultural obstacles, and improve cancer screening rates and outcomes for historically marginalized racial and ethnic communities. To address these obstacles, ACS-CAN is advocating to ensure that all eligible individuals can access affordable, comprehensive healthcare through Medicaid expansion. We're working to ensure that cancer patients who receive Medicaid have adequate access and coverage without barriers to care, like work requirements. And we're working to support making permanent the enhanced subsidies provided in the American Rescue Plan and expanded in the Inflation Reduction Act that help people better afford their premiums and cost sharing for coverage on the marketplace. We're also working to help maintain the non-discrimination protections of the Affordable Care Act that help reduce discrimination in healthcare for people of color, and working to ensure that everyone at risk for or diagnosed with cancer can access patient navigation services. From the cancer research perspective, we know that drugs react differently across racial and ethnic groups. Black individuals make up less than 3% of pharmaceutical clinical trial participants, while making up 13% of the US population. Most cancer patients, including Black patients, are willing to participate in trials, but only a fraction enroll due to inequitable access and greater barriers. Inclusive trial enrollment improves detection, access, and treatment for not only Black people, for everyone though. In terms of research, ACS-CAN is working to ensure that the Henrietta Lacks Ensuring Cancer Research Act works as intended. It works to increase access and remove barriers to participation by underrepresented communities in federally sponsored cancer trials. We're working to pursue passage of the Diverse Trials Act, which would increase diversity in trials by reducing barriers, including limitations on ancillary costs such as travel, lodging, and parking. We're also working to promote key implementation of key steps to provide equitable pharmacogenomic or PGX discovery and implementation. PGX testing is a form of personalized medicine that helps us understand how genetic variations are associated with clinical effectiveness or even toxicity of drugs. When it comes to early detection, we know that cancers where there's a screening tool, Black people have a lower 5-year survival rate than white people overall, 63% to 68%, and for each stage of the cancer diagnosis. Specifically, Black women have 8% lower cancer incidence rates than white women, but a 12% higher mortality rate. Also, Black women are 40% more likely to die of breast cancer than white women, and Black women have the worst survival rates across all stages and all breast cancer subtypes compared to women of other racial and ethnic groups. We also know that prostate cancer rates for Black men are 70% higher than they are for white men. Black people are about 20% more likely to get colorectal cancer and about 40% more likely to die from it than most groups. And the early detection of cancer through screenings increases the chances of finding, treating, and surviving cancer. To address these stark disparities in early detection, ACS Can is urging Congress and the states to adequately fund the National Breast and Cervical Cancer Early Detection Program, commonly referred to as BCEP, which provides access to breast and cervical cancer screenings and diagnostic services to women with limited incomes and without insurance. We're advocating for the PSA Screening for Him Act and for state legislation that would require health insurance providers to cover prostate-specific antigen or PSA blood tests for the highest risk patients like Black men at no cost. We're advocating for the Medicare Multi-Cancer Early Detection Screening Coverage Act that would expand access to cancer screenings in Medicare once they're approved by the FDA and a clinical benefit has been shown. Potentially, multi-cancer early detection, or MCED tests, can find more than one type of cancer at the earliest stages from a single sample of blood, helping to reduce disparities. We're working to ensure access to and coverage of evidence-based early detection services, including follow-up testing with no cost share to the patient. And we're working to ensure the colorectal cancer program's funding is maintained or even increased to improve screening rates for high-need populations and reduce the health inequities by serving those most at risk. I want to turn to our final and a topic we've heard about before, commercial tobacco control. When you hear the facts, you understand why this issue is important. And the facts are this: lung cancer is the leading cause of cancer death, for Black men, and the second leading cause of cancer death for Black women. About 80% of lung cancer deaths result from smoking. From 1980 to 2018, in the Black community, menthol cigarettes were responsible for 1.5 million new people who smoked, 1.5 million life years lost, and 157,000 smoking-related premature deaths. 83% of Black adults who smoke use menthol cigarettes, which are easier to start and harder to quit. Nevertheless, tobacco companies continue to use targeted, predatory tactics to unfairly market more and cheaper menthol products in Black neighborhoods, magazines popular in the Black community, and events in the Black communities. As an organization, our goal is to overcome these decades of destructive and deadly methods and to save lives. We aim to do this by encouraging FDA to end the sale of menthol cigarettes and all flavored cigars, highlighting the impact the targeted marketing of menthol cigarettes has had on the Black community. In addition to encouraging FDA, we are also supporting efforts at the state and local levels to end the sale of menthol cigarettes and all their flavored tobacco products. We're also advocating for culturally relevant, inclusive, and barrier-free health insurance coverage of tobacco cessation services that help individuals quit using tobacco products. And we're working to address systemic racism by strongly advocating that tobacco control laws are not targeted against individuals who use or possess tobacco products. When we are discussing enforcement actions, we cannot ignore the clear and controversial facts. Communities of color, the Black community in particular, are too often subjected to targeted and violent enforcement actions. That is why ACS Can, along with our partners such as the Center for Black Health and Equity and the African American Tobacco Control Leadership Council, are focused on policies that protect individuals and target the manufacture and sale of these dangerous products. As I said at the beginning, the facts are clear. I know I've thrown a lot of facts and figures and data at you, but I think it just illustrates that our work is still, what the work remains ahead of us. So let me end by saying this. ACS Can is excited about our work with organizations focused on eliminating inequities and disparities and uplifting the Black community. Thank you for being here today, and we look forward to continuing our work together.
Thank you, Sonja and Nishith. Coming up is a discussion about addressing the gaps that often remain unaddressed across cancer continuum, shedding light on challenges and opportunities for improving cancer surveillance, prevention, treatment, screening and early detection, supportive care, and survivorship. Here to moderate this distinguished panel is Ina Wanliss, the National Partnership Lead for the Division of Cancer Prevention and Control within the Centers of Disease Control and Prevention. Ina?
Well, good afternoon, everyone. All right. I know it's after lunch, And we are among the last sessions before the end of the day. So I want to thank you for being here today with us. This is my third State of Black Health Conference, and I have to say it gets better and better, but I just wanted to publicly say how much I've enjoyed it. I look forward to the next conference, but most importantly, I'm constantly empowered. I feel also the benefits of meeting all of the folks that I've had the opportunity to meet while I've been here, especially the young individuals, because we're here to pass that baton on to you. And we look to you, the future generation, that's going to help to hopefully make a bigger difference than we have made so far. So our session today, as you know, and as has been mentioned already, is focused on looking at those unaddressed issues as it relates to cancer control. And so I'm pleased to bring to the stage with me my other presenters today. And in order of how they're going to be seated today, I'm inviting Nikki Hayes, who's the branch chief and within the Division of Cancer Prevention and Control for the Comprehensive Cancer Control Branch. And I should have also mentioned that I'm not going to be providing a detailed description of their bios, but as they are presenting today and sharing, they will be introducing themselves individually. Our next presenter, and I'm not sure if she's here as yet. You haven't seen her? Okay, well, we'll move on to Sonja Chambers, who will be joining us as well, as she's the executive director with the Patient Advocacy Foundation. Is Dr. Katherine Tossas with us yet? Okay, welcome. And Katherine is the director for the Catchment Area Data Alignment Office of the Health Equity and Disparities Research, Virginia Commonwealth University, and with the Massey Cancer Center. And our last presenter was supposed to be Jayla Burton. Are you here with us? Wonderful, come on up. And Jayla is the project manager with the LGBT Cancer Network. All right, are we ready? All right, we'll go ahead and get started. And so I know we only have an hour, and I've noticed that most of the sessions have gone over. So we're just going to go ahead and jump right on in. So we have a general question, and I'm going to be directing it to all of our participants here today. But what essential discussion are we overlooking, or crucial factors are we failing to acknowledge or address, which are adding to the cancer burden within Black communities? And we can start with Sonja in the middle.
Starting in the middle, that's always trouble. So good afternoon, and give yourselves just a round of applause just for having staying power, right? We always talk to our communities about having staying power, but for having staying power. And thanks so much for that question. I think the last panel really positioned us really well, because, and others have said it across the last few days, about the importance of us looking. We talk about the social determinants of health, but I want to bring that down a little bit more to really give us an opportunity to look at social need gaps that are actually caused by unaddressed social determinants of health. And so what am I talking about when I say that? I'm not just talking about the need for socialization, but I'm talking specifically about things such as transportation, such as unstable housing or unsafe housing. I'm talking about economics and finances, which we really have to desegregate because they are not the same. We're talking about access to healthcare, not just the availability of healthcare, but access to quality healthcare, because all of us can think about our respective communities, and we know that the healthcare delivery on one side does not look like the healthcare delivery on another side of town. But these are the very real issues that individuals across the country are dealing with. At Patient Advocate Foundation, we see this play out all the time. Last year, 2022, we served about nearly 180,000 patients across the country. And we're addressing non-clinical barriers to care, right? Because guess what? Within the four walls of the healthcare system, everybody can be fully compliant because they have someone that is consistently administering their medication. They have someone that's consistently bringing them 3 meals a day. They have someone consistently really providing the support that they need, and it's a safe environment. But that's not the social context or the reality of people's lives. And so we have to think about not just what goes on in the four walls of the healthcare system, but what goes on in those four walls in the community, because that's where people are dealing with every single day. These are the conversations we're not having.
Okay. Dr. Sofa?
So good afternoon, everyone. I want to echo Shanta and first of all say thank you for staying, because that beach looked awfully inviting to me too. So thank you. I think that we have heard this also throughout the course of the conference. What's missing is representation. Representation is missing not only in the places where we might be looking at the data, it may be missing in the places where we're looking at where services are, but it's also missing in the places where decisions are made. And so I think that one of the things that we can all do is that we can get involved. And I say that, and I do come with the bias because I do represent the CDC and I represent particularly the National Comprehensive Cancer Control Program, but there are cancer coalitions in every single state in this country, in the District of Columbia, and in several tribes and territories to include right here in Puerto Rico. But we don't always see us at the table. And so sometimes we need to stop waiting for people to bring us stuff. And I'm not insinuating, I don't mean to insinuate that that's what's happening, but we don't have to wait. We can go and we can command and we can do these things. So what I really want to encourage everyone here to do today, when you go home, find out who is the leader of your cancer coalition, find out who leads your comprehensive cancer control program, because there is one. And join that coalition. Join that coalition so that you can always bring to the surface and bring to the table the conversations that need to be happening about how we really address the inequities that we see in health that are creating the disparities that we see in the communities that we quote unquote serve. The only way that we're going to make a difference is if we prioritize making that and those differences important. And we do that by putting that in our strategic plan. We do that by making sure that that the decision makers who decide where the money goes, who decide where the resources go, that they know our names, that they know who we are, and that they know that if we are not included in the conversation, we're coming. So I want to encourage you to get involved, because I think that that's one of the things that's missing.
Jayla, will you also answer that same question?
Yes, of course. And again, I echo everyone here on this stage. Thank you for being here. A little bit of background of where I come into this work. So I'm currently at the National LGBTQ Cancer Network. And I, similarly to like what you're saying about like pulling up a seat at this table, I actually lead a program that is for emerging BIPOC, LGBTQ, trans leaders that are interested in getting into spaces of public health. And we're really trying to get them interested in working into the cancer space. So yesterday, one of the fun things about being able to present on a Friday while everyone is at the beach is that I get to also synthesize some of the things that we've heard throughout the week as well, right? So yesterday I sat in on the panel about LGBTQ health and aging. And one of the things that Dr. David John said is a quote that is going to stick with me probably for the rest of my time in this field and probably through anything that I do, is that data is a tool for white supremacy. And when I'm gonna say that one more time, data can be a tool for white supremacy. And so what does that mean? Well, first, we are not represented in a lot of the data that comes into the cancer world for a lot of reasons. I think one of the main reasons is when you look at the NIH and who's funded through the NIH, the NIH has put out, they have put out studies of their own that have said that Black researchers and scientists are not funded at the same amount or rate as white scientists are. So if we're not even leading our own scientific efforts, how are we supposed to ask our people to participate in those clinical trials that we're not represented in, for example? So I'll stop, I'll get on my high horse, and that's that's why I'll answer for that question. But I just wanted to add on to that, to what you said, Nikki.
Dr. Tossas, you get to wrap us up with that question.
So I don't know what other questions are coming, but y'all sent me down a spiral asking me what kinds of conversations we're not having in the Cancer Continuum.
That's correct.
Full disclosure, first of all, bienvenidos a Puerto Rico. This is home. Welcome home, cousin. Because one of the conversations we're not having that you guys have started is that we all, brothers and sisters, same bus, different bus stops, right? And so that's one of the conversations that, we need to have more of. So thank you for having the vision, the foresight to call upon your other brothers and sisters on the other side of the ocean, because we are here and we need to have more of these conversations. So that's one of the conversations we're not having. But I don't know what other questions you got. I also, in the meantime, before I forget, I put on your tables as a welcome. There's a little fruit on the table that looks like a grape, but it's not a grape, Del Monte. It's called quenepa.
Yeah.
And quenepa grows on a tree that is predominantly in the south of the island, because I'm from Ponce. The rest is parking. I had to say it. Sorry, that's right. Ponceños are very proud. They're like Texans. And so I want you to try the quenepa as a, welcome to the island. And I hope that you guys come back and again, remember that we are here, your other brothers and sisters of African ancestry. But I think if you can, hit the slide, I have one slide, if that's okay.
Yes.
So this is my family. And so it's about the conversations we're not having. So there's two things that first popped up on the top left-hand side. Again, it's my family. Some of the conversations we're not having, you guys have started it. Yeah, we talk about racism, right? And we talk about, Black, etc. But we talk less about colorism, right? And we talk less about the fact that there seems to be an inverse relationship between pigment and outcomes. Right.
Mhm.
And so that's actually a little harder, because some of my, light-skinned folk, right, be like, but y'all know it's happening. It's kind of hard to quantify. And here in the island, it does manifest. I want you to take a look when you go to the CVS. If you forgot your baby oil or you forgot your, deodorant, look at the magazines and look at the pictures of the socialite class in Puerto Rico. Look at the elected officials in Puerto Rico. And look, I am a very proud Puerto Rican. I am what is called a coquí, because I'm actually from here, born and bred. But these are things that are happening, my brothers and sisters. We talked a little bit about this earlier on. But one of the things, and this is going to keep rolling because I asked him to time it because I can get on the roll, but we've talked about disparities, and we just love to talk about disparities. And Lord have mercy, do we know how to measure them? Right? We just heard it from the gentleman from the ACS CAN. Oh my God, I say to my students, I teach a course that's called Fundamentals of Cancer Health Equity. And I said, if you learn nothing else, if there's ever a question on a quiz or an exam that asks who fares worse on cancer of your choice, what's the answer? Correct. So, we know how to measure them. We know they're there. What I think the conversation we're not having, and we also use disparities and inequities oftentimes in a very similar manner, but the conversation that we're not having is that the difference is on the ethical judgment, right? And the example that I like to use is folks that smoke are more likely to die of lung cancer than people who do not smoke. That is a disparity. All disparities are differences, not all differences are disparities. And the difference between disparity and inequity is on the ethical judgment of whether you think that a smoker should die more of lung cancer than a non-smoker, right? And so that one's kind of easy to digest. You can be like, people choose to smoke. I mean, they should suffer the consequences. But people can say the same thing about, now we're talking about abortion. People can say the same thing about affirmative action, right? And so that conversation, that divide on our ethical judgment is one of the conversations that we're not having, right? I think that's important. Another conversation that we're not having, is the talk about digital divide. We talk about the digital divide all the time. There's a digital divide, right? But what we're not talking about is that the digital divide is not at the individual level, because that picture there is Mr. Jones in the middle holding that beautiful vegetable. He is a farmer from Brunswick, Virginia. He has a master's degree, has 3 sons that have graduated from Ivy League, and he has the same cell phone that I have. He has a nice iPhone, right? No problem. So it is not about him not being able to get the equipment. It is not about him not understanding how to use the equipment, okay? But in Brunswick, Virginia, where he lived, ain't no 5G like up in your house. So he got to go. His phone only works on the framework of his bathroom. Do you hear me? In the meantime, the other picture in there is Dr. Eric Topol, founder of, I forgot the name of the company at the moment, but basically he diagnosed his own kidney stone with his cell phone, right? So, but Mr. Jones, who got the same cell phone, can't do that because he don't have the same access to. So it's not at the individual level, right? So what we're not talking about, right, is about that kind of apartheid, that, technological apartheid that is related to the structure, not to the individual, right? So let's elevate the conversation from the social, and I like social drivers, not determinants, because that is not deterministic. We can change them, right? So they are drivers. So that's the conversation we're not having. I think the other one that I want to focus on is actually on this last quadrant on the bottom left-hand side of your screen. So again, I said, we are experts at measuring disparities, right? And that map is Chicago. I lived in Chicago for 20 years, and it shows mortality on the pink and gray areas, highest in the neighborhoods in Chicago that are predominantly Black and brown. Chicago is the 4th most segregated city. The little ribbons represent an overlay of the mammography facilities, right? So we're really good at that. And I'm an epidemiologist, right? I always had to work full time. So one of the many jobs I had, I was a director for a small nonprofit that collected data from mammography facilities on 11 breast cancer quality metrics. That's another one that, is another one of my many, soapboxes. And then I would sort that data, and I would, can you roll it back or pause it so that people can see the bottom one? I would sort that data, and I would visit the worst performers. And that picture that you see there, that you probably already noticed that there's a manhole in the mammography facility, is from one of those facilities. And so I walked in, and I, very benevolent with my data around, data as a vehicle for white supremacy. That's interesting, right? Because, poor things, they really need my help to give them this train the trainer program to retrain them in compression and positioning of the breast so they can get better images and not miss a cancer. And they were like, I'm sorry, what's your name? Right. So, but just saying, she was like, what's your name, Kathy? That's cute. Come here, Kathy. So your data is really cute. That's really sweet. But you don't understand that we have the 2 remaining analog machines in the city that only have capacity for about 24 women. They schedule about 38 a day. They think that we have lots to follow up, but we don't, because we get a lot of our clients from this down the street residence program for women that are on methadone, and they bust them here. So they don't miss their appointment because they bring them here. And the majority of our patient population is obese, kyphotic, arthritic. So they have a really hard time being positioned. They also have large breasts, and I don't have a plate to accommodate the size of their breasts. Do you see my light boxes? They're missing 3 light bulbs. I order them, but they're in back order, and we don't have the money to, fix them. And also, I have a manhole in my mammography facility, and that's why I have to wear this mask, because it smells. But none of those data points are on your data. Mm-hmm. So your data is really cute, but your data is highly insufficient. And so access to care is not enough. Access to quality care is not enough. It's what we need to be talking about. We also need to be talking about the inadequacy of our tools to measure these things, and about what data points we're missing by not talking to our communities. And the last one that you see there is the conversation that we're not having around supporting our leaders. So we need representation. That's really crucial, right? And we're like, we'll go out there and we will, go and support and try to get our leaders elected and get them in there. And when they're there, like, I'm gonna need you to do magic. I'll put you there, so what's up? And so every 4 years, or, we're in this cycle where then our leaders fail because you walked away from them, because You put them there. Congratulations. I'm gonna need you to go and do your thing, do magic. They need our support. We need to support one another. And I put an example of one of the ways in which we can do that, for example, is building more partnerships between minority serving institutions and minority serving institutions, right? Oftentimes, minority serving institutions prefer to partner with predominantly white institutions, right? And so how are we going to grow if we can even partner with each other? The biggest tool of the oppressor is division.
Yeah. Well, you've touched on quite a lot.
Done.
And I know you were getting to the end, but I want to go back to one of the key areas that you focused on, which is around leaders. And so I'm going to start the next round of questions because it ties in nicely with that. And so over the past couple of years, I'm going to direct it first to Nikki. Over the past couple of years, we've shifted our conversations about the disparities that we see in cancer, health outcomes across the populations to look at more upstream causes. Has your organization embraced this shift, and how? If so, how?
So thank you for the question, Ina, and I think that this piggybacks very well on what we've just talked about. So yes, we have. At CDC, we are like others, and we recognize that it's time for us to stop talking as much about and designing our research and our communications and our programming around those markers that we know create these inequities, but more so look at what it is that we can do so that we can remove these disparities and we can resolve these inequities. And so we've started doing a lot, building on some of the programs that are institutional to the agency, like the National Breast and Cervical Cancer Early Detection Program and the Colorectal Cancer Screening Program, where we have created access to services, but we're going beyond that now. And we're using the work that we've done through these programs, as the foundation for looking now at, well, how do we create access to the data so that we can better understand those social determinants or those factors that really are influencing the inequities. And so we've added questions to the BRFS survey, and that data will be coming out. The 2020 and 2021 data will be coming out sometime this month, but there are questions that are very specific to health equity and to the social determinants of health on that survey. And so we're hoping that as you see those modules and the responses in those modules, you can use that to help in your planning efforts. We've also expanded our place data set so that, and now we have data for all of the countries across the county so that we can look at the health outcome data, we can look at the risk factor data based on the census tracts, and we can get a better understanding in these small area places and spaces and in these zip tabular areas about what the health outcomes and the health issues are in our communities, and then plan do our program planning around that. We've also expanded our PRAMS data set so that when we're looking at pregnancy risk assessment data, we've got health equity questions in those assessments now, so that we'll be able to look at and see, well, what are some of the issues that we're seeing that we know are causing that are contributing to the fact that we see that Black women have higher mortality in childbirth than any other race of women. And so we are doing more to expand our surveillance systems. We're doing more, we've invested a lot more money into programming that looks very specifically at understanding the social determinants and then creating planning so that we can invest in the interventions in those specific determinants. So that, yes, we are looking at, we understand, my boss says all the time, I don't want to see another study to figure out who's desperate. We know where the disparities are. Now I want to see what are we going to do about it. And so that's what we're doing now, is we're putting significant investments in those places and spaces. And I want to encourage you again, and this is, we can't advocate, but I really do need you all to go out and advocate for the fact that this data is important. This type of work is important, because whereas we have the opportunities today, we haven't always had them, and we may not always have them. So we really want to make sure that we are doing the work that we need to do internally and through these very meaningful partnerships to make sure that it is available.
And speaking of partnerships and working at the community level, like Patient Advocate Foundation. So I'd love to hear your thoughts relative to that same question.
So even before I touch on that, I want to also highlight something. that Nikki didn't talk about, really about CDC's leadership and actually realizing that cancer and tobacco-related disparities don't even present the same or mean the same thing across very specific population groups. And as a result of that, the significant investment that the Division of Cancer Prevention and Control and Office of Smoking and Health have made in funding 8 national, now 9 national networks to really say, help us understand what these disparities look like among Blacks, among low-income individuals, among the LGBTQ community, among Hispanics, et cetera. And I just wanted to underscore, because that's the recognition that, yes, we have these evidence-based interventions. Those of us who have been trained in public health, we know we got these catalogs of evidence-based interventions, but we don't necessarily know the application or the effectiveness of these interventions around priority populations. So to be willing to make that type of investment, so we begin to augment these interventions in a way that really meet the needs of the population. At PAF as an organization, as I mentioned before, we're really at that nexus of access and affordability, really getting at what are these other barriers that are preventing people from being able to access care. And it's funny, you show the picture of Chicago. I know what actually health system that is, because we've been doing work in the South Shore and North Lauderdale, et cetera. Because if you look at population level data in Chicago, it will actually tell you that the breast cancer mortality disparity between African-American and Black women is actually declining. However, if you start looking at subpopulation data and look at Chicago's South Side, you will actually see communities where the breast cancer mortality is increasing. And so as an organization, we didn't want to go into as if we were going to be some kind of hero. We wanted to understand from the community, what do you see as the things that are contributing to these disparities? More importantly, what do you think are the solutions? And then it's about us as a national organization. So I really implore all of my national organizations that are represented in this room, right? When we say a rising tide lifts all boats, we have to be willing to bring our brand recognition to help these frontline community-based organizations that are on the front line. If we can't fund them, we can at least bring them into the rooms where they're not currently in the rooms. And so that is what that is how we really begin to get to the issues in North Lauderdale and South Shore and Roseland community. We have to be willing to go into these communities that Monday through Friday from 9 to 5, not when it's convenient or when we need, but when we really want to truly understand what's going on in these communities. And then we think about this as a relay, realizing that in some communities, we might need to be the lead runner. In another community, we might need to take that second or third leg. But in some communities, we might just need to be the anchor to help bring that community forward. So it's about us making sure that we understand the context of the community first before we think we have the resolution or the solutions for those communities.
Jayla, you get to finish that up for us?
Yes, and I don't know if I'm going to answer your question, but I'm going to respond to everything that has been said. I think that context is really important in terms of looking at our systems and how we're breaking down our systems in order to serve the people that need to be served the most. And when I think of that in terms of when you're talking about place and how built environment, which we just had that whole discussion, which was very timely to this discussion, of how in a I'm going to transition this to a policy sort of thing, because we're not in these positions, or the people in Chicago are not in those places by coinkadink. They're there on purpose because they were placed there. That's the built environment, correct? So I think what is really important when it comes to something that's also missing from this work is, like, we've done a lot of work in the cancer space around making sure educational campaigns to make sure that people are going to get screenings, going to, know their body so that they can be able to understand when something is off and when they need to go get checked, right? But we haven't done a lot of the work to, and I don't even want to chuck it up to us not doing the work. There's a lot that's going on, especially when you hold so many different identities, that gets in the way of us doing this work. For example, I did a lot of work in the community partnerships that I did with research was a lot of work in the environmental justice space and how there are environmental risk factors that cause cancer. I was the only person of color, usually sometimes the only Black woman in those rooms most of the time. And I was thinking, why am I one of the only people here? Well, when they're having a discussion of, oh, there's all these toxic chemicals that are in the products that we're using, but someone is walking into a beauty supply store and being worried about being followed around because they're being profiled, they're not going to check to see what kind of toxic chemicals are in the hair products or the facial products that they use. And so there's like these, I don't know. So I don't know how I got into the cancer space. I'm gonna be real honest with y'all. But it's because of all these intersecting reasons of all this work that we have to do to break down a lot of other areas and a lot of other issues is why I continue to stay in this work. So I don't know if I answered your question, but that is my response to this discussion that's going on right now.
Wow. Powerful, powerful. So we can shift off, if we'd like, on to the next question, because I know we have quite a few that we have identified. So looking forward, how would you envision the landscape? So as we talked about all these different issues and how things are now, so what do you see or envision some of the changes that will need to be made specifically around cancer treatment, care, and prevention?
I mean, I always got an opinion. What changes need to be made in terms of cancer treatment and prevention to change the landscape? I mean, I'm a basic scientist turned cancer epidemiologist, right? Like sort of now cancer health equity researcher. And I say that the more I learn epidemiology, the more I realize policies where it's at. And the more I learn about policy, the more I realize history's where it's at. And there's a criticality of us learning our history. And we've gotten a lot of that in this conference, which is really great. So I just want to like sort of continue to elevate your what you just mentioned around the importance of policy, right? So, you know, one thing that I have there too, and I forgot to mention was the context, for example, of the electronic health records and the collection of social drivers of health within electronic health records, right? So, you know, for access to occur, we have to understand context, and to understand context at the individual level, for example, that's an opportunity for a tool. That tool is there. There are many hospitals and institutions that have tools to collect social drivers of health in their electronic health records. But it doesn't happen because there is not an investment in a system and a process in place to make it systematic, to make that collection systematic. That can be changed through policy. And I do think that that would make a difference in terms of, you know, access, uptake of treatments, right, and prevention. You know, my mother was one of 6. You know, I grew up in those neighborhoods. I'm the first 2, etc. My mother had cervical cancer at 33, breast cancer at 41, colorectal cancer at 49, and she ended up dying of sepsis at the age of 59. My mother had diabetes, high blood pressure, high cholesterol. She was obese. You know, and every time I was the only child as a result of her having cervical cancer so early in life. And we would go to the doctors, right? Because, I mean, she had tons of doctor's appointments, so much so that then, of course, her cancers were thankfully diagnosed early because she was seen a lot. And so people would go and they would give her pills for her diabetes and pills for her high blood pressure and pills for her. And they would always tell her about how she needed to lose weight. But, you know, nobody ever asked. We were being abused at home. We were food insecure. We, grew up around violence. Nobody ever asked those questions. And still to this day, right? Those questions are still not being asked. And so, you know, I remember, you know, working in Inglewood and working in cancer and, oh my God, you know, you should get your screen. Can I get you in for screening? Blah, blah, blah. And I remember, you know, women, more than one telling me, can you tell me why our babies are dying? And I was like, what? I'm a cancer researcher. I don't know nothing about no babies dying. Our babies are dying. My sister's baby died. My grandbaby, you know, just died. And finally, I started to look into it. Infant mortality was 24 per 1,000 live births in the neighborhood of Inglewood. And it's about 4 to 5 per 1,000 live births in the United States. Why? And so we started to listen, and we actually shifted our research to learn about infant mortality. So another thing that needs to change is listening to the community. What's important to them? Because we need to also build trustworthiness, right? Not trust, we always talk about how there's lack of trust in the community, lack of trust. Well, I'm not going to trust you if you're not trustworthy. So for me to give you my trust, you need to be trustworthy. So I think in addition to policy, institutional trustworthiness is another thing that probably needs to occur so that we can change the paradigm around, access to care and treatments.
One of the things that we're doing around social determinants and looking at how we address the social determinants to advance health equity is really looking, of course, at built environment and looking at how we create these community clinical linkages and looking at how we do things to increase tobacco cessation and really promote that. But we also are looking at social connectedness. And so again, how do we get folks in the room so that folks feel empowered and feel like that they are valued, that they matter, and that they're empowered to help make decisions around our community's health. So for what I envision, and I'm just talking very personally for my own personal family experiences, but I envision a time and a place and a period where we talk about cancer. And because in my family, we don't. My grandmother is of that generation that it was called C. You didn't say it out loud, and Lord knows if it was ovarian, you just pointed down there and said, it's down there, don't talk about it. And so I want us to get to a place where we can talk about it, because the very aunt that I loved so much that my grandmother said we couldn't talk about her ovarian cancer, 30 years to the day, my best friend, her daughter died of breast cancer that I didn't know she had until the week that she died, because she didn't want to talk about it. Her sister, who had a double mastectomy, and I decided at her funeral, and I didn't know until then that she had a double mastectomy, that we were going to talk about it, because that's one of the issues. If I don't know my family history, then I can't be my own advocate when I go into my doctor's office, and I can't press and insist on the things that I need to insist on, because I'm not moderate risk. I'm at high risk, but I need to understand how to have those conversations. At the same time, I understand why it's hard to talk about, because we do die 40%. We are 40% more likely to die of breast cancer than any other group of women. And so if I'm diagnosed, I'm not going to be as hopeful. My mother died of a massive heart attack, and I tell this story all the time. I know for a fact that when her doctors told her 6 months before she died, you have an aneurysmic bulb at the base of your heart. If you do all of the things that you're supposed to do, then you will live a long and healthy life. Now, she went in there a smoker. She lied and told him she didn't smoke, but she went in there a smoker. She was controlling her blood pressure with you drinking green tea. She said, I got it. I'm just going to do this. I'm going to do this, this herbal stuff. And she wouldn't have the conversation. 6 months later, she had a massive heart attack. My sisters were very upset, and I thought about it, and I said, but you know what? I don't know that we can be mad at Mama, because her mother and her father died of massive heart attacks. And the reality is, I don't know that she knew of anybody who looked like her, who had what the doctors told her she had and survived. So I think as cancer survivors, especially as Black cancer survivors, we got to tell our stories. We have to tell our stories so that our communities feel empowered, so that our communities feel like there is hope. And so, and I think that to me, that's what the future looks like. We're telling our stories, we're being our own best advocates, and we're making sure that not only are we advocating for ourselves, but we're advocating for all of those around us, so that we are in the middle of the conversations and people aren't guessing about what I want. Because I'm here to tell you what I want. I'm here to tell you what's important. And so for me, it's us becoming our own best advocates is what I envision.
Can I jump in here?
Absolutely.
Okay. I really like where this conversation is going. And I think another big part of the conversation is the different identities that we hold as Black people. Like, for example, I'm thinking, and I'm always uplifting and centering my queer and trans family and the conversation that comes into play when they're at risk of cancer, any type of cancer. They don't even feel comfortable going to the doctor to get checked up on for their blood pressure, for anything, let alone let it be a disease that is, a gendered disease, and they might feel very invaded by. So one of the things that we're doing at the Cancer Network is providing trainings for providers, for community organizations, for people that are in our network, so that they can understand what are some of the other intersex that people have when it comes to cancer and how to address that. So thank you for sharing your story, Nikki.
And I will say that I'm glad you brought up that point, because the answer is not homogenous. You know, like we don't, because I know we did a focus group around colorectal cancer. We had a group of men, and this was in faith community. We had men in one room and women in the other room. And the women, we were sitting in there, we were writing out some cancer messages. We would have these long stories, and we were this, that, and the other. They were real flowery and whatnot. We passed our messaging to the men, and they were like, oh no, I'm not reading that. That's too much. You know, the men wrote their messages, and it was basically just do it. And we were like, just do what? You gotta be more. And they were like, nope, that's all I need. So I think that as you know, as we are developing messages, as we're developing programs, we need to understand you got to talk to more than one. If you talk to me, I'm not speaking for the entire race and the entire community, gender, and you know. So but there's so much richness, you know, in our community, and I just think that we all do so much better if we take the time to learn it.
And Ina, if I can add to this, I think we've learned a lot, especially in the cancer space, around the benefit of navigation, right? We learned a lot about the importance, the benefits of navigation to get women to screening, through screening, to treatment. Why don't we take that same knowledge base and actually navigate folks in a way where we're addressing their social, financial, and other needs? Because again, as I work with Chicago-based organizations, other organizations who may be in a very specific space, whether it's navigation, what have you, they are uncovering all of these gaps. And they are dealing with the frustrations because they know that these are needs in their communities that they are unable to meet. So one solution that my organization, Patient Advocate Foundation, more importantly, my colleagues at our National Patient Advocate Foundation, the advocacy side, we are actually going to be leading federal legislation to standardize social needs navigation so that it becomes a part of standard of care. Because what we forget sometimes is that it's hard being poor. And nobody said, today I think I want to be really, really poor, right? And so let's not assume that people are dignified, and let's not rob them of their dignity because we're asking them whether or not their lights are on, or if they do have a refrigerator to put food in. Let's just make it standard of care. We don't ask them, is your blood pressure high? No, we come and take those vital signs. Right. So let's start taking their social, economic, and financial vital signs. So when we are making recommendations around care, we don't label people as non-adherents when at the end of the day, they're just hungry.
Yes. Wow. I know we're at the juncture now where we're supposed to entertain questions. I don't want to rob the audience of questions. So if there are folks that would like to ask a few questions, we can do that now. And if there are no questions, microphone, if you could go to the microphone, please.
Good. Hello. Okay. Good afternoon. My name is Monique French and board member with the center, but also a lung cancer survivor diagnosed at the age of 36. So my question is, what are we going to do to ensure that our young adults are getting appropriate screenings that they need to get? Our population of African Americans are getting cancer at a higher rate, and they do not know the resources nor the appropriate steps to take in order to get the care that they need at the earliest point needed to ensure that we have survival.
And I thank you for that question. In particular, I just want to emphasize colorectal cancer in particular, especially for young adults. African American is on the rise. So thank you for that question, and I'll pose it on to the panel.
So the first thing that I say is that, you know, that's where it's up to those of us in the room to help to make sure that there are resources available. And so we need to make sure that people understand how to pay it, how to recognize symptoms, and then how to advocate for themselves when you go to the doctor and say, this just doesn't feel right. And the doctor says, well, you probably have a little gas, you know, just keep pushing that one. Two, continue to be in the conversations where we are pushing, where we are moving guidelines, because we really are looking at the data and we're making sure that people understand, especially in certain communities, you can't wait to get screened at 50. 45 is important, 40 is important. And so we need to stay in those conversations. And then we need to make sure that as we are in those conversations and we're influencing those decisions, that our community also knows. I know we had a conversation at our church, and when I told my pastor, who's 60 this year, and I told him, I said, you know what, I want to do something around colorectal cancer screening here at church. And he says, okay, well, tell me what is colorectal cancer? Because I don't really know what that is. And I'm looking at him like, you a 59-year-old man, you should have had a colonoscopy 9 years ago. What do you mean you don't know? So even people who are at moderate risk don't understand the risk and what we should be doing. And so I think we have an obligation to make sure that we do all we can do to increase awareness from trusted messengers, because I think that being a trusted messenger is extremely important.
And I would simply ask, I think we also have to tell the young survivor story around lung cancer, because the current guidelines from U.S. Preventive Services Task Force recommend lung cancer screening starting at age 50. We have heard over and over in numerous sessions how some people have started tobacco use at 15. So if you started at 15 and you don't get your first lung cancer screening to 50, that is 35 years too late. So we have to tell the young survivor story of lung cancer so that those who are making those decisions, they understand the true impact of those decisions.
Yeah, and I'm gonna follow up real quick, Dr. Bob, real quick. I'm a non-smoker and worked in this field for a long time. So when she says the guidelines are not adequate, I had a cough that did not go away, and they thought that it was pneumonia. So I was on antibiotics for 2 months before I got diagnosed. So it's when you're thinking about health equity, and I'm fighting as a patient advocate to live to see my boys, it's serious out here, even against ours. So we have to stand up and speak for those who don't know what to say, because it's happening to all of us now.
Question up here, please.
Yeah, I would just like to comment first, the kind of leadership that is represented on the stage is absolutely marvelous. But I would say that all of you are operating with one arm tied behind your back, because what is absent is a rigorous construct of community. We need a community-driven paradigm. So, and some specific comments. In terms of the racialization of data, there are social scientists that do not want to collect data on race because they do not consider race a viable scientific variable. So we can talk about the need for data all we want, but if we are not prepared to challenge that analysis, there are battles that we will lose simply because there are insufficient numbers of us in the room when those policy decisions are being made, and the data that we need will be excluded because of some construct that says it's not a scientifically viable variable. And if we do not have a concept of race, we are also not going to have a concept of community. The social determinants, you can look at the social determinants as a continuum in terms of it's asset-driven and problem-driven. The problem is that one, the people who are driving the social determinant construct, and I'm for it, but I'm for it as a tool, as an analytic tool. I'm not for it as a construct that leads us. It will not take us to community. It does not. It is not a community. Community is not inherent in the social determinant construct. And if that's all we're talking about, then we're missing the boat in terms of developing community-focused. When you look at the social determinants of health, most of the people who are using it are epidemiologists and doctors. That's a cohort of people that are problem-based, medical model-based, individual-based. they will not analyze that data in a way that facilitates an understanding of community. And it's not that it's not there potentially, but it's that we don't have the workforce with the appropriate mission and understanding that's going to utilize that tool. And it is only a tool. It is not a conceptual framework. It's a tool. The notion of making an ethical choice between people who have the problem and people who don't have the problem. When we were fighting the Uptown cigarette in Philadelphia in 1990, which was the first example of the African-American community rising up against the tobacco industry. And I was at the Fox Chase Cancer Center in Philadelphia, and I helped lead that coalition. A very conscious decision we made was not to pit smokers against non-smokers. The problem of Uptown coming into Philadelphia was a problem for the Black community. So we made a very intentional, conscious decision not to be divisive in terms of how we catalyze people who it was a problem that impacted all of us, and it was also part of the variables that helped us be successful in getting R.J. Reynolds to take Uptown off the shelves within 13 days after we organized. And finally, I'm sorry. Okay, well, I just want to make a final comment in terms of the national networks, which actually, when I got to CDC in the Office of Public Health in 1993, the first thing I did was develop the national network application, and it was always about community and community development. And when we get to CDC, their data, it comes from the census tract. We're missing the community, and we might get to it in terms of subpopulation analysis, which is helpful. But what CDC needs to do is develop a center on community prevention. Let the Center for Chronic Disease and Cancer collect all the data about the problem that it wants. What CDC needs is a center of prevention that is totally community-focused and solution-focused. And in that way, perhaps we can begin to make some strategic gains instead of 10 years from now, having the same discussion then that we're having today.
Thank you, Dr. Bob. Really appreciate your comments. So timekeeper's telling me that we have less than 5 minutes. So I'm going to have our last person pose your question, please.
Wonderful. You guys are giving me hope. I am a community organizer. I stress and I am an expert in community engagement. So when I'm hearing about community being transformative because of COVID, that gives me hope. We've been organizing mobile mammographies in 2001, going to churches and parking lots. But with the Affordable Care Act, I want women and men to be able to have medical providers. So I don't want to have all this mobile. I understand that some communities. So I'm also proud that the Green Foundation, where I represent, gathering resources to educate and empower, is community engaging. We have community health advocates to go out in community. There need to be more. And how to do that is funding, no different, as I've shared before in another session. So I just want to let you know that we are a recipient of the Centers of Disease Foundation for 3 consecutive years, help supporting to get the information into communities, that the information that is needed and how important it is for prevention. And just as one of the panelists was saying about her pastor wasn't aware of colorectal cancer. Well, whose fault is that? Is he not gone to the doctor to be able to recognize that when you need to be screened? So it's not just the individual. I think there's a bit disconnect in what resources that are at the community, at the local level to help get that information out. So I heard people talking about investing. Yes, invest in the organizations that's been around for a number of years, because we do know what we're talking about. So I am hopeful, because what all of you had shared about engaging the community and community focus, that is where it's at. lot. So I just appreciate all of your comments and your thoughts to keep this conversation, not just talking about it, but we need to just do it. And I could say the data-driven, put the money where the data is saying where it is lacking.
So we are actually out of time, but I do want to thank our illustrious panel and also to thank you for taking the time to spend with us. And that completes our session. Thank you.
How about a big hand for our panelists and Dr. Wanliss. A lot of interesting information. So at this time, how you guys doing? Everybody's feeling pretty good? So one guy over here, maybe one or two over here. How you guys doing? All right, so here's what we're gonna do. We're gonna bring back Dr. Chris Omni to facilitate a breathing break for our well-being and Black joy. Come on, Dr. Omni, come on, help us out. Give her a round of applause.
Greetings and gratitude. Thank you. Hello, my queens. Now that was rich. Thank you so very much. Hello, my brothers. Yes, that was rich. Hello, everyone, my beautiful, beloved soul flowers. Yes, thank you. My name is Dr. Chris Omni, and I have you for the next 15 minutes. But I want to tell you just this much about my background, just in case you did not hear me yesterday or you didn't have a chance to get your freebie. I'm giving out freebies today in case you didn't know. How many of you have already received a freebie? Okay, I see hands up. I see some waves. All right. Well, as he already mentioned, my name is Dr. Chris Omni, and I am a proud product of Topeka, Kansas. Kansas is the sunflower state. Yes, thank you for even knowing where Topeka is. But I reside in Florida right now. So if you know anything about Florida, we going through some things, y'all. We going through some things. So the idea that my research is even taking root in a state that is having so many problems, and I don't have to mention names, but you know who's at the head of those problems. But I research Black joy. I am a Black joy scholar, artist, and activist. And there are so many different definitions of Black joy. There's Black joy in dance. There's Black joy in movement. There's Black joy in song. But for me in particular, I narrow it down. Black joy in green spaces is what I research. So I look at nature's influence on the physical, intellectual, emotional, social, and spiritual well-being of Black women. But what I'm bringing to you today, since I like Mother Earth, I love Mother Earth, I'm going to bring you in a grounding exercise. So this is not an academic space, but to let you know, if we need to turn it into academics, we can, because there's research around what happens when we commune with Mother Earth and when we have a chance to be grounded. So I invite you in this moment, if you would like, to take your shoes off. Only if you like. You're like, all right, maybe not. And some of you are. And then just feel this carpet and imagine that it was Mother Earth for right now. I've been walking around barefoot all day, today and yesterday, because I love to remain grounded and connected to each and every one of you, because then in this space, I'm connected to my ancestors, and then they download to me for me to give to you. And what I received this morning is a message that consists of 22 words that I'm going to leave you with for this conference. If you feel comfortable, we're going to start with breath work. You may stand if you would like to get a long space of breath, or if you want to stay seated, you can. So now's your chance to either stand or sit. But if you're sitting, sit up tall, throw your shoulders back, chest forward. You were so ready for this. You're like, come on, let's bring this. Yes. And I promise I'm still giving you freebies when I'm finished with this. This just isn't the freebie. So yesterday in our breath work, we did chakra breath work. So we started with the root and we went to the heart and we stayed in these two spaces. But today we're only going to be in the heart chakra. So please put your right hand over your heart and your left hand over your hand. And in this space, I invite you to breathe in through your nose. Let your shoulders go back. And exhale through your mouth. Continue as we engage in this collective breath. Inhale and exhale. Thank you for letting me hear your breath. The work that we do as public health professionals, and I come from a 25-year background in this space, and a new foreground in art education, where I bridge narrative inquiry with public health to make public health look at these deficit narratives in a different way. Because even though we know the statistics, 100% of us still live with joy. I told you the story yesterday about my mama and being able to watch her take her last breath. But today's story is about my dad, because my dad almost died from COVID. And I watched my dad deteriorate right before my eyes. COVID forced him into retirement and changed who he was, but he never lost his love of God. He never lost his love for gardening, and that's what brought him back. So as we breathe 2 more times, I want you to breathe for somebody who is not here or somebody who almost did not make it. Let it be deep, y'all. Inhale. And exhale. Inhale. And exhale. So my word for you, or message for you, consists of 22 words. And this is the interactive piece. So you may continue to hold on to your heart if you like, or you can just stand firmly planted so that these words can just sink in from the crown to the root to the ground. Because what I'm doing is planting a seed for you today, so that when you leave, you may water that seed. While you are in this conference space, people will pour into you and water this seed. But it's only 22 words. And I hope that you can help me with these words only if they touch your heart. This is the heart chakra mantra. My heart is open to receive the energy of love. I radiate this essence. I walk my path with ease and grace. We're going to stay here for a little while. And if it starts to feel good to you, feel free to say it with me. And I'll just break it down. My heart is open to receive the energy of love. Rewind, let's put it together. Say it from your soul like you mean it, because we're talking to you in your spirit right now. My heart is open to receive the energy of love. I radiate this essence. I walk my path with ease and grace. Since you've already said it and the timer's not running, and I don't know how much time I have, but I can keep on talking. But you already said that your heart is open to receive the energy of what? Love, and you can fill in the blank with joy, happiness, whatever it is that you want to fill that in. But For the love and the freebies that I'm giving to you, I want to give you a hug. Come on now. I heard the because the work that you do, the work that we do is so heavy. The statistics that we always report, so heavy. So if this was a research study and I presented it to myself, my research question would be, who cares for the caregiver? My second part of that question would be, what happens when Black people give themselves permission to let being be enough? So I'm about to drop down from these stairs and invite you to do what you just said for the heart chakra mantra. But before we do that, I want to open this up to anybody who identifies as a Black man. I want to hold you. I want to share and sprinkle some love on you. And this is just a pure space of sisterly, brotherly love. That I saw a queen earlier today that had a t-shirt, and I couldn't make this up if I tried, because I know that this is divinely guided work. Black men have emotions too. Her shirt said, Black men have emotions too. So in this moment, I come downstairs and I invite men to come up and just let me hold you for a little bit. Then after that, I'm here for anybody and everybody, because my heart is open to receive. All right, I'm Chris Omni, y'all.
Come on down, Black man, and get yourself a hug. We're going to keep the train moving. Coming up is a word from our sponsor, the American Heart Association. Please welcome Eric Batch, the Vice President of Field Advocacy.
Well, good afternoon. I first want to just thank the center team for the opportunity to spend a few minutes with you this afternoon. The American Heart Association, we are so proud to sponsor this conference, and I'm especially proud that our leadership saw value in partnering in this endeavor. In the time that I have today, I want to do three things. And so I want to share a resource that the Heart Association has. I want to talk about some of the work and commitments that the Heart Association has made specific to health equity. And then I want to leave you with a call to action. So the ad that you have in the conference program has a QR code that you can scan to learn more about Life's Essential 8. Life's Essential 8 comprises of two major areas, health behaviors and health factors, that focus on barriers that exist and are especially relevant for many Black Americans. The health behaviors, there are four: eating better, being more active, not smoking, and getting healthy sleep. And when you think about how stressful and taxing our lives are, eating healthy, exercising more, quitting tobacco if you smoke, and getting 7 to 9 hours of sleep each day, they're not easy, but they're essential and contribute greatly to improved cardiovascular health. So let me talk a little bit about the health factors. There's 4 of them: managing weight, controlling cholesterol, managing blood sugar, and managing blood pressure. High levels of blood sugar, as we know, can damage your heart, kidneys, eyes, and nerves. So managing blood sugar is extremely important. And with 1 in 3 African Americans suffering from high blood pressure, I can't stress how important it is to know your numbers. And as much as Life's Essential 8 is a great resource to take back to our communities, let's not forget to look inward and think about which of these we may need or want to work on. When you get on that plane back home, the flight attendant is going to say, in the event of an emergency, put your mask on first before you can help others. So take care of yourself so that you can be strong and healthy for those that depend on you. The bottom line is that you can't pour from an empty cup. You can't give what you don't have. Next, I want to talk about some of the investments that the Heart Association has made relative to health equity. Like so many organizations, in the summer of 2020, we looked internally as we reflected on the gross injustices that we were seeing in this country that culminated with the murder of George Floyd. And we made 10 public commitments to remove barriers to health equity in all areas of our work. And while I don't have time to touch on all 10, I want to touch on a couple. One of the things we did is that we invested over $100 million in new research programs and grants, and that includes our HBCU Scholars Program. We also invested over $120 million in organizations working to improve health through our Social Impact Fund, our Bernard J. Tyson Impact Fund, and our Community Issues Campaign. And the third thing that we did is that we're leveraging our advocacy, our science, and our news media to hold those accountable that abuse and harm our communities. And that includes big tobacco and big soda. I also want to talk about a collaboration with Bank of America. They've invested $25 million over 4 years to launch the Collaboration for Equitable Health. It's a joint venture between the Cancer Society, Diabetes Association, and the University of Michigan School of Public Health to advance healthy outcomes for people in communities that are historically underserved. And you'll see some of the success that we've had at the bottom of that slide. Let me come back to this for just a second. I'm gonna hold here. And finally, I want to talk about this call of action that I have for you. We spent the last 2 days really digging into issues that Black people face relative to health. And we cannot leave here and go back home and do things the way we've always done them. And as I was thinking about what I wanted to leave you with, I had to ask myself, how do I possibly say what hasn't already been said? So I want to share a quote from a book I recently read. One of the contributing authors is a guy named Matthew. And here's what he had to say about the work that we do. For I was hungry and you fed me. I was thirsty and you gave me a drink. I was a stranger and you invited me into your home. I was naked and you gave me clothing. I was sick and you cared for me. I was in prison and you visited me. And so when we take these words and layer on the current context of what we are dealing with in our communities, our work goes from public health to a divine appointment. So let me break this down and make it really plain. I was hungry and you fed me. People in our communities are hungry. People are not just hungry for food, though. They're hungry for a better life in a better way. And as professionals in public health, we can help them. It is important that we help them get good food and nourishment for their bodies and improve the systems that produce and deliver that food. And sometimes you can be hungry and not know what you want. Some communities lack the power to determine their own destinies. And in instances like those, we need to come to our community with resources and solutions. I was thirsty and you gave me a drink. Our communities are thirsty, quite literally in terms of access to water and less access to sugary drinks. And we need to figure out how to get our communities water. But they also need refreshing and need to be hydrated emotionally and financially. And we need to ask ourselves, what can we do as public health professionals to bring that refreshment? I was a stranger and you invited me into your home, homeless. Where's my safe place? Our communities need safe places where they can go and get care and information and help. As we leave here, we've got to think about how we bring together public agencies, community-based organizations, nonprofits, and advocates to raise awareness and fix the broken systems to serve us better so that we don't feel like strangers. I was naked and you gave me clothing. Now, it could be physical clothes, but naked also means to be without covering. When our communities are uncovered, they're vulnerable and exposed to the elements. We are getting burned by the heat of the things that systemically operate against us. We're getting rained on by the systems that time and again fail Black people, and we need covering. I was sick and you cared for me. I was sick. Now that's an obvious one. That's the intervention piece. We kind of have a handle on it, but we can do so much better. We've made progress with things like the Affordable Care Act, but disparities still exist for us. We're also sick in the sense that doctors are seeing diseases in Black folk today that they used to see in much older patients: heart disease, type 2 diabetes, stroke. They all appear at younger ages for us. And because we tend to get diagnosed later, we're living longer with these conditions. And let's continue the conversation from yesterday about women's health. Why are Black mothers, my grandmother, my mother, my wife, more likely to die due to complications from pregnancy and childbirth than pregnant women of all other races? And it doesn't discriminate between those Black women who are well-resourced and educated and those enduring economic hardship. While genetics may play a role in certain instances, we can't ignore the socioeconomic factors. And while this crisis is getting more attention, there's still so much more work to be done. I was in prison and you visited me. I was in prison. I'm locked in my community. I don't have access to preventative care. I don't have access to good food. I don't have access to safe streets to walk. There are tobacco retailers, liquor stores, and fast food restaurants at every corner. Organizations like mine can tell you to walk 10,000 steps a day, but what do you do when your community isn't bikeable or walkable? Or it is, but you don't feel safe to do so? We can tell you to eat better, but what do you do when there aren't places to buy healthy food? Or what if you can't afford it? So what do we do with all the great information and strategy that we got this week? We go home and build an army of people, and we bite off a bigger chunk and make the connection between intervention and prevention. Now, we're good at intervention. We must get better at prevention. It's one thing to tell people how to manage their high blood pressure after they have it. It's another thing to dismantle and disrupt systems so that they don't get it in the first place. Because once you have high blood pressure, you are intervening because it's a life or death situation. We're in a war and we're not fighting properly, but we spent the last couple of days in Puerto Rico getting tools and resources and making connections with like-minded soldiers so that we can go home and re-engage, so that we can go back home and save the bodies that have been impacted by the war. Intervention is what we have to do. Prevention is what we must expand. We need to reimagine our work and strive towards systems where people don't get type 2 diabetes, aren't suffering from mental illness, where they don't get cancer, where they aren't over-policed and under-resourced, and where they aren't getting heart disease at alarming rates. In short, we have to be able to see it the way that the guy that Matthew wrote about saw it. People are suffering, and we can help carry that load from an intervention and a prevention perspective. And so when you get back home, be like Sha'Carri Richardson. Don't just be back, be better. Thank you. Salute.
Thank you, Eric. So we're in the home stretch, folks. Bear with us. Yolanda Lawson, MD, board certified OBGYN and associate attending at Baylor University Medical Center. She has a genuine passion for the physical, emotional, and overall health of women. Please welcome to the stage the current president of the National Medical Association, Dr. Yolanda Lawson.
Good afternoon. Good afternoon. Thank you all for being here. I was trying to figure out early what I needed to do. If I had time, I was going to ask for a Bacardi or rum cart or something to hold y'all in the room. I couldn't figure it out and I didn't have enough time. But those of you who stayed, thank you so much for allowing me here and just give me grace today. I want to, I know it's a long day. I'm going to take you through a lot of information. I don't want to overwhelm you, but be clear. I haven't been present for all of the meeting, but I've peeked my head in the room a couple times. I sensed some energy I sensed passion, but I also sensed some frustration at times. And so I hope today you'll allow me the grace. I'm going to present some data. I'm going to present and do a little sharing. I'm going to take you through a little historical journey, if you will, but I'm going to root us. We're going to root, and then we're going to come to, and we're going to talk about some solutions, some challenges. We're going to dive in just a little bit, and I'm going to do it, but just bear with me. And again, give me grace. So thank you again for inviting me here, allowing me the space to share with this audience. Let's see. So again, Yolanda Lawson, the 124th president of the National Medical Association. And we were formed in 1895. I am going to give you a little bit of history about the organization. So the National Medical Association is the largest organization of African-American physicians in this country, okay? So many people often wonder, what was the importance of having to join an organization? So historically, there was the American Medical Association. In 1869, some Black physicians, they had continually tried to get into the AMA. And the reason it was so important, for licensure, physicians needed ongoing training and education. And to get hospital privileges to work in a hospital, you needed to be a part of the organization. And so that's why it was important. So these doctors kept going, they kept going to conventions, they kept being walked out, they kept being voted out. And in 1895, after a 26-year struggle to integrate the white medical societies, a group of 12 African-American physicians met in Atlanta, Georgia during the Cotton Exposition and formed the National Medical Association and the First Congregational Church. Just last summer in Atlanta, it became a historical landmark. So we were all there for that, and it was an amazing day. And so as you take a journey through the years, by 1905, there are about 400 Black medical professions in the United States. And so we formed a journal. The Journal of the National Medical Association was formed in 1909 and is still relevant and present today. For those of you who are writing and putting out projects, I encourage you to submit for publication. We want to take care of our Black scientific authors. We do that. I'm going to take you again. Now, in 1939, the AMA discontinues calling us colored. So in the journal, when you look up the doctors, we were called colored. That's when they stopped that, okay? In 1945, we're protesting at VA facilities because, again, we want to integrate. I'm going to take you through the 60s. 1960, there are 26 medical schools in the South, of which 12 don't allow African Americans in entry. So in 1961, 8 members of the NMA register for the AMA meeting, and they're arrested and carried out because they're in a whites-only dining room. NMA in 1963, AMA is fighting legislation around getting Medicare passed. We are there every step along the way. This is very, very important. In 1965, when the Civil Rights Act and Medicare and Medicaid legislation passed, what that allowed, what was tied to that was integration into the hospitals. That's 1965. We were advocating for that. Our president there was right at the side when that was signed, okay? 1968 is the first mention of the AMA to seek ways to allow African Americans in medicine. You come forward to 2008, the president of the AMA came to our national meeting and publicly apologized to the NMA. And then in 2021, you may have heard Nathan Davis, when you heard me talk about those doctors back in the day that kept trying to get in, he was the Dr. Nathan Davis, former president of the AMA, who really led the charge to keep Blacks and women out of the AMA. His bust was just removed 2 years ago. So the NMA, we've had a long history of lobbying, advocacy, and we fought to desegregate not only medical schools, but also nursing schools. Our policies, I've listed some of our policies here. We do a lot of work in health equity, public health, maternal mortality and reproductive justice, violence. We formed a new council on violence. We're doing a lot of work in that space, physician workforce diversity, social justice, all of these things, many have been talked about today. We're right alongside you doing that work also. I want to explore briefly with you a few of the challenges of Black physicians. So I don't know if anybody here can relate to this. When I got to medical school, I remember going into the diversity office the first week, and the lady sat me down, and it was Miss Linda. She worked in the office, and she said, "Now you got to work twice as hard. You got to be twice as good to make it through this medical school." Can anybody attest to your mother? Anybody, you know what I'm talking about? You got to always work twice as hard and be twice as good. I'll never forget, Miss Linda said that to me. And so being held to a higher standard. So I'll tell you what bothers me most. It's a word, I just have to share this with y'all. I'm in the doctor's lounge and I hear it almost every time I'm there. He's such a good guy. And when I hear a white man say that, something goes through me, because thinking about all the standards and through school and always being held to a different standard than your white counterparts. Black physicians go through that also. Black physicians, you may have seen some of the data. It was all over the news this summer. It was on CNN and everywhere else about Black physicians make up about 5% of the physician workforce in this country. And why that's significant is because the Black population in the United States is around 13 to 14%. So we know there's been this strive to get to racially concordant care. Racially concordant care means there are enough Black healthcare providers to take care of the Black population that exists. Because we know multiple studies have shown outcomes are better for whatever reason, but we know what that is. Black women account for 2.6% of US doctors. 37% of doctors are women, but now this younger population, we see those under 35, about 60% are women. Also, there's limited advancement opportunities. Academia, a huge area of disparity educationally for institutions. The little James Baldwin never hurt anybody. People are trapped in history, and history is trapped in them. So I'm going to bring you forward now to Black and minority health. So in 1983, Margaret Heckler was the Secretary of Health and Human Services. Margaret Heckler went to Congress. She had commissioned a report. She went to report to Congress on the health of America. And I'm gonna read you verbatim what she said. She talked about Americans living longer, infant mortality was continuing to decline, and the overall American health had shown almost uniform improvement, but there was a continuing disparity in the death and illness experienced by Blacks and other minority populations as compared with our nation's population as a whole. Ever since she talked about this, that's when it started being recorded, once she then proceeded with the report on Black health, the Black and minority health report. It was published in 1985. At that time, the task force identified 6 causes of death that accounted for about 80% of mortality for Blacks and other minorities. Those 6 are listed here: cancer, cardiovascular disease and stroke, chemical dependency, measured by deaths at the time due to cirrhosis, liver cirrhosis, diabetes, infant mortality, homicides, and accidents. Those are those unintentional injuries. That's 1985 when this is published and taken before Congress. So I got to thinking, where are we now? I pulled up just some news articles. Many of the same things they talked about in 1985, we don't have much difference now, right? All of those things you could sit here, opioid epidemics killing us, infant mortality is high. So not much work has been done, or much more progress, I should say. So I'm gonna roll back again. I'm gonna go back in history again. Some of you may have heard about the Flexner Report of 1910. So Abraham Flexner was commissioned by the Carnegie Foundation, the American Medical Association, Council on Education to survey the quality of medical schools in America and in Canada. This revamped the entire medical education system. There were higher admission and graduation standards. They were to adhere to strict protocols of mainstream science in their teaching and research. Chapter 14 of the Flexner Report talks about the education of the Negro. And it speaks to the rationale to train Black physicians. And really it was to take care of the Black population. There was an impact on medical schools that we still continue to face today. So in 1904, there were 160 MD granting institutions with over 28,000 students. In 1920, only 85 MD granting institutions remained, educating around 13,800 students. And by 1935, 66 medical schools were operating in the United States. By 1900, about 6% of practicing physicians were women nationwide and accepted into only 91 of the 155 medical schools, including there were 3 at the time exclusively educating women. By 1940, 4% of physicians were women, and then women began to catch up in the 60s, but still lagged behind males. And the proportion of women graduated medical school decreased to an all-time low shortly after the Flexner Report to 2.9% and remained below 5% until the 70s. So some of these things, we've talked a lot this week around policies and those long-term effects. Flexner advocated for closing all but 2 of the historically Black medical schools. So we had 7 Black medical schools at the time. And after the Flexner Report, only Meharry and Howard were left standing. And currently today, we have 4 African-American medical schools, and so proud to say that there are 2 new medical schools coming on board. Some of you may have heard, Xavier University and Morgan. Absolutely. And so we are in complete support of that. So the trajectory of those limitations, again, here we are decades and decades later, and we're still feeling the implications of what happened in 1910. So if it had not been disrupted, if that had not been the disruption, the implications of the health of the Black community, we still feel those ramifications today. So to today, we have a disproportionate impact on the physician workforce as far as it relates to Black physicians based on what happened in 1910. So as I stated earlier, just 5% of physicians are Black. And so it's been projected that if all 7 medical schools that educated Black physicians in the early 20th century had remained open, and we have an additional over 35,000 Black physicians in the workforce today. Flexner wrote that women show a decreasing inclination to enter medical school and that those who did have obvious limitations. Black students should be trained as sanitarians. It hurts me to say it today, and should protect whites from disease. So the initial thought in the first place to really train Black doctors was to protect the white folks from Black disease in our dirtiness. And so that's why there was this thought around training us, but really to be sanitarians, to protect the Caucasian population. So he states a well-taught Negro sanitarian will be immensely useful. An essentially untrained Negro wearing an MD degree is dangerous, is what he wrote. And so, again, the closure of those medical schools has had a negative impact on not only Black physicians, but women physicians on the medical profession until this day. So I'm going to explore really briefly and quickly and take us through some of those mortality numbers and disparities that we just talked about. You all have probably heard this week a little bit on infant mortality. Okay, so Black infants are almost 4 times likely to die from complications related to low birth weight as white infants. But much of that has to do with Black women typically are higher risk for preterm birth. So that's an entirely different conversation. Much of that comes from the complications from preterm birth. Health disparities in the US. So again, of industrialized countries, The US has the highest maternal mortality rate. Okay. We know that these third world countries, again, high. We know the rates are really high in Africa, but when you look at industrialized countries and what the US spends on healthcare, we rank number one. And I want to make mention, that's all women. So the numbers came out after the pandemic. We looked at those numbers this past spring. All women fared worse in the US. It's just that there's a disparity between that gap and Black women. So we know the numbers. Black women are about 3 times as likely to die from pregnancy-related complications than white women. Many of those deaths are preventable. And we're more likely also to deliver at lower quality hospitals. So it's not only about just a care and an access, it depends, the quality of your care matters tremendously. And again, we know that education is not protective. When it comes to Black men, you just heard the panel just talk about cancer. Thank you for those insights. Yesterday, I couldn't attend because I presented was the to the president's cancer panel was yesterday. And so select organizations, NCCN and others, ACCR, everyone in cancer presented to the president's cancer panel yesterday. And so some interesting thought that was stimulated throughout that meeting. I was really happy to represent yesterday and be a voice that needed to be heard from a perspective that needed to be heard when it comes to our people. And so they asked me if I had one thing I needed to tell the president. I was like, I only get one. I only get one, but I snuck in 3, be clear. I did it in a way I've learned how to navigate politically. So Black men, we talked about this a little bit yesterday, actually at the president's cancer panel. And so repeatedly, almost every agency, entity, and organization that spoke yesterday, I don't care if it was the American Cancer Society, everyone was very similar in their messaging. The concern over the workforce, the concern over inequity, and the concern over access. And that access, whether it be to services and for payment. I spent some time yesterday talking about payment. I talked about people being insurance poor. People have insurance and still don't get the care they need, whether it's they can't afford the copay. I don't know what it is, but you know what I'm saying. People have payment, but they can't even still get the access. So we've got to make screening more accessible. So Black men have about a 6% higher cancer incidence than white men, but a 19% cancer mortality. We're doing some work within the organization, many of our Black urologists. So the NMA is composed of 26 medical specialties. So we have everything from dermatology, urology, pediatrics, OB-GYN. We have 26 medical specialties. We're divided into 6 geographic regions, including the US Virgin Islands. And so through much of our work, is done through either our sections, the medical specialties, or through the regions. And so the urology section of the NMA is doing some really important work around prostate cancer, recognizing the mortality disparity. They're forming a registry for Black men with prostate cancer. We hope that this will be the largest registry for African-American men in the world. We're looking at how we use that to leverage their participation in clinical trials and get the representation of Black urologists, training, we're doing mentoring. So there's a lot of work in this space that we're working on actively right now because the numbers are staggering. So Black men are about 73% more likely than white men to be diagnosed with prostate cancer and more than twice as likely to die. And that's staggering. I know in my own personal family, I have numerous cousins and uncles right, with prostate cancer. So it's something that, of course, interests me. The numbers, the panel before us talked a little bit about Black women. We have a lower incidence of breast cancer, but we have a higher mortality than white women, okay? And then lower survival at almost every stage of disease. And so yesterday, part of the conversation as I talked to the president's cancer panel was this conversation on screening. But that screening conversation then turns into early detection. I probably was in 6th grade, and I remember that if you find it early, it saves lives. your outcomes are better. We've got to really advocate. So there's a piece around resources and these things, but how do we dispel and make sure our communities that we're advocating that the screening and taking away that fear of screening? Because I have cousins that tell me, I mean, I deal with this in my own family. I lost a dear friend. He died, my brother's classmate. He probably died, he was at 53 from colon cancer. And I remember one day being on my hands and knees, begging him to do a colonoscopy, begging on my hands and knees, because I knew what his symptoms were, and just so resistant for whatever, right? I think his issue was cost, but we've got to just push past. And so what struck me, and so this is what bothers me, and being a Black doctor in this country, is when we see premature death. We see preventable death. And that is a struggle, is something that's very difficult to reconcile. But after he died, I remember everyone started a GoFundMe for the family and for the funeral. And I thought that GoFundMe should have been made before so we could pay for his colonoscopy. So we've got to wrap around people, because this is real, and this is real what we see. So again, Black Americans have the highest mortality rate of any racial and ethnic group for all cancers combined, and definitely most major cancers. And again, breast cancer became the leading cause of death, cancer death among Black women, and lung cancer continues to be the leading cause of death among Black men. I put Puerto Rico there because yesterday, actually at the President's Cancer Panel, American Cancer Society actually talked about Puerto Rico. They talked about Puerto Rico and how low the lung cancer rates are here now, just because of the government's initiatives around decreasing smoking. And so again, these policies, and you'll hear me at the end of this talk, we're going to keep talking about and weaving in policy pieces and how we work together to move things forward. Cancer mortality rates, I know this is very difficult to read, but all sites, whether it be esophageal, colorectal, pancreatic, if you look, the second column, there are Blacks, our mortality rates are just higher than others. And much of that, again, advanced disease. There are some, there was a lot of discussion yesterday around biomarkers and all these other things. But I want to say a comment. I think you got up and talked about your diagnosis. And I think one of the panelists on the stage earlier talked about telling our stories. If I leave here, and I didn't get to give my comment earlier, but I'm a physician, right? I see patients in the office, and we take a history, or y'all have to fill out things in the EMR or fill out paperwork. And a lot of times there's a question on there about family history. And I will tell you, and this is everybody, it's not just Black folks, Hispanic, it's everybody. What did your grandmother die from? Cancer, maybe, I think. Or maybe that was Aunt Bertha. Okay, cancer where? Oh, she had it down. Somebody said it, down here. And so for us, it's very, very important. So when we're asking certain questions on those questionnaires, the entire time I see you, a patient, I'm taking risk assessment. Because some of that history is so important on your screening, because there are such things as you may want your insurance company to pay for screening, but we can't just randomly order things. We have to substantiate it. And many of the time, your family history, I deal with my own family. Mother went to the doctor. My grandmother died from complications of diabetes. She was amputated, both extremely, died within 2 months after from gangrene. So my mother goes to the doctor, my brother goes with her. And my mother lives in a separate state. I couldn't be there. And so I call after the doctor to get a little, hey, how did it go? What happened? Tell me what the doctor said. And I always ask a lot of questions. And my brothers hate it. I'm the only girl. I have 3 brothers. And my brother said, I fixed you this time. I recorded it. I recorded the whole interview with the doctor. I said, okay, let me listen. The doctor asked my mother and my brother about my mother's medical history. My mother was having extremity issues, peripheral vascular disease. The doctor says, is there a family history of blah, blah, blah? And my brother and my mother are both in there telling the doctor, no, we don't have nothing like that. And I screamed, my grandmother died from, she was amputated with gangrene. And so that disconnect. But my mother and my brother both gave the doctor incorrect information. And so it is so important. I'm finding out things about my family because I'm inquisitive and I'm always asking. But it is important. If I tell you anything else, know that history in your family and bring that forth. It is so important for your holistic care. Cardiovascular disease. We know that Black people are more likely to die of heart disease than any other ethnic groups. We have a similar prevalence of heart disease as Hispanics and white people. We just end up dying more so at higher rates. Black women, there's a project we've been working on, Release the Pressure, collaborative between the American Heart Association, actually working with the American Medical Association, all of us, because Black women are some of the most hypertensive beings on the planet. We have got to do better. And so you're right. I heard somebody talking about the supplements and the herbs and the garlic and the all of these things. And that's fine if you choose to do that. Take your blood pressure and make sure it's working. Because again, it is painful as a Black doctor to see premature and preventable death. I just lost a patient, age 42, diabetic, hypertensive, third stroke, killed her 15-year-old daughter, only child. And, I take care of the daughter and I'm just part of the family, I guess, because I remember being, again, on my hands and knees, literally begging her to take her medicines before the first stroke. And so this is real. And I say, just take care of yourselves. That's all. I'm going to leave it at that because I'll get emotional. Again, heart disease by race at the top, very hard to read, are Black people in the blue, white or in the green next, and then our American Indians are the third line there. Again, just showing you the disparity gap for hypertension for Black folks, diabetes, again, twice as likely to die from diabetes. And then 3.2 times more likely to be diagnosed with end-stage renal disease as compared to whites. So you think about the South and why there's dialysis clinics everywhere is because Black folks in the South, lots high rates of diabetes, okay? Again, percentage of folks over 18 with diabetes. To the left, you see American Indians, Black people at the third bar, in the middle are Asian friends and our Hispanics overall. So Black, non-Hispanics and Hispanics fairly equal, just slightly higher. But and our American Indian, Native American colleagues, of course, have extremely high rates of diabetes and disparities. And this is the trends in diabetes, type 1 and 2 in our children and adolescents noted. And over to the right, type 2 diabetes versus type 1 diabetes. So white children have a higher rate of type 1 diabetes, which would be insulin dependent. Your pancreas just does not make insulin. Type 2 diabetes can be due to obesity and other things, but is acquired and can also be reversed. Type 1 is not reversible, but type 2 can be, and the orange line are African-American children. Again, another disparity. Opioid deaths, we talked a little bit about this, how the increased rates of overdose. And one of the issues around why Blacks are dying, we're less likely to pursue treatment before we die. So very unlikely to pursue treatment. Black men, about 7 times as high as white men to die of an overdose. Homicide and violence, we know these numbers, the disparity is most significant in our youth, and homicide and cardiovascular disease tend to be the leading drivers of premature mortality. Again, homicide rates about 4 times higher in Blacks versus white young adults. HIV, the numbers again remain to be staggering. This has become a disease state now mostly limited to the South. So where we're seeing new infections and in Black populations, this is just a brief infographic to show and demonstrate to you the disproportionate impact of HIV disease in Blacks, 41 per 100,000 versus 16 per 100,000 in our Latinos and 5 per 100,000 in whites. That was interesting. Here in Puerto Rico, new infections for whites about 1%, 99% in the Hispanic population. Lifetime risk of HIV diagnosis by your ethnicity: Black men, 1 in 22 lifetime. Black women, 1 in 54. You'll see Hispanic men, 1 in 51. And Hispanic women, 120, 256. So there's a lot of initiatives and work around Black women and HIV. So I have 3 pillars going into my presidential year. One is the healthcare workforce and some of the racism work and things around Black physicians, our resident physicians, and of course, getting students into medical school. The second is around digital health equity. And the third is my Black women's health agenda, and HIV is within that. I do a lot of work at a community-based organization in Dallas where we primarily deal and treat HIV disparities. And if you're an MSM, that number is always so striking. I know you know it. 1 in 2 Black MSMs, their lifetime risk for acquiring HIV. COVID-19, we know the numbers. We know that we fared worse. We saw the disparities widen and narrowed over the course of the pandemic with those viral surges, as you recall. But again, Blacks and Hispanics were twice as likely to need to stay in the hospital. So Black health determines the health of a nation. We've just demonstrated, and I showed you a little bit on the deadly toll of health inequities. And so we know that we've got to reduce some of these social and institutional inequities, improve living conditions. Some of this talk around housing, water, air, all these things matter. And these drivers of health disparities. Some of those drivers I'll run through really quickly here. I like this slide because it just really lays it out for you. It could be economic instability, neighborhoods we've talked about, zip codes, it matters, your zip code matters, education. One of my passions is around literacy. I think we have to do more work around healthcare literacy. I think that, I'll give you an example. So I'm an OBGYN in Texas. And so, you know, while we've just had more of these recent legal issues, one of my issues has been for the longest sexual education. Just without sex ed, I think we have 32 states maybe that offer it, and it's limited. I mean, I'm teaching grown women the menstrual period. So there is a place, and we've got to advocate for things like that. And so it is very difficult to have these elevated conversations around care and what these things mean when there's not the literacy and the capacity to understand. You all are real smart and fancy in this room. I get it. But we've got to really think about, especially those of us working in these community-based organizations, just the basics around health literacy. I see an extreme gap that we need to work on. And happy to work with any of you on that, because I love my public health people, because y'all get the messaging right. Y'all do all that fancy little talk, and I love it. It's important, and we need it. Healthcare system. So what I say to you is there could be any of these drivers, whether it be social or economic, but just one single one could change your entire life course around disease state. Solutions. So they asked me to talk about what did the NMA see as some of the challenges that we're going to face in the future. The end of Medicaid continuous enrollment, we're quite concerned. The folks coming off the Medicaid rolls and leaving an uninsured gap. Overturning Roe versus Wade and the impact of that on maternal and infant health. And so while I argue, because it's always framed around abortion, and what I say is we're not advocating for anyone to go get an abortion, but there are healthcare needs women have. And while it's framed as abortion, there's still a healthcare need women may have that's outside of an elective abortion or termination of pregnancy. Mental health and substance use. Again, Black folks being willing to accept mental health, pursue and get mental health providers and get treatment for substance use. I just had a patient come in to see me, and this is the first time this happened to me. Her drug dealer told her he was worried about her and to go see the doctor. I have never had a drug dealer refer the patient to the office. Racism, discrimination, and violence. So we have formed a violence task force and a formal council of the NMA doing some wonderful work in the area of violence. And I'm looking for partnering and alliances with other organizations. My ask to this group would be to help us on healthcare misinformation and disinformation. It is harming us. It is killing us. It is keeping people from living their best life. Important task force. And then again, the healthcare workforce. And so while we talk about diversity of the healthcare workforce, we think about the burnout. And so what I say is when you hear, and I'm sure everyone is hearing these things around burnout, but when white doctors are burned out, what do you think is happening to the Black doctor? So be honest about what that means. I just lost a dear friend who committed suicide. My soror, an emergency room doctor. And so we within the organization, we've had a rash of Black women physicians committing suicide. Reframing the discussion around DEI. And so we have some concerns around that. So we'll be having content at the Congressional Black Caucus. If you are there, you're welcome to attend NMA's Professional Development Series. A senator a few months ago told me, you guys need to you need to rethink how you're discussing it. No longer using these words equity, diversity. He said, go use language such as justice and fairness. I said, okay. So we got to get a new name for it. And so I talked to some of the old doctors and they said, yeah, that's what we did all through the 40s, the 50s, and the 60s. We just kept renaming it. So join me, my public health colleagues. We got to get a new name for DEI. Y'all work on that. Healthcare spending. So again, reframing discussion, let's talk dollars. Every agency, institution, everyone here needs resources to sustain. And so healthcare spending, 16% of the gross domestic product in the US is around healthcare, and it's increasing. And so that economic burden is higher for who? Blacks, and also the less educated. So your education again translates to a higher economic burden on healthcare. Federal programs taking advantage. We have a sense of urgency now. The administration right now has some open ears, know what that means. Policy, that's where I see the alignment. I mentioned here briefly, taking opportunities, the Office of Climate Change and Health Equity, the Unite initiative around structural racism and racial inequities in biomedical research. We have a Project 2.0 within the organization. We're working on not only Black researchers, increasing that number, but enrollment of Black patients into trials, and forming alliances with comparable policy goals with other organizations. Here, the health in all policies. This is a CDC paradigm. The healthcare is embedded into these policies that are created. All too often, we're the beneficiary of policies, but we're not at the table. And so yesterday, I think it got really quiet because while everyone at the end of the meeting, they kind of got everyone together to kind of give last thoughts. And I said, you know, all of you, there were so many CEOs, the CEO of this and that on the meeting yesterday. And I said, well, all of you keep talking about diversification of the healthcare workforce. I haven't heard one person mention diversification of your advisory boards, your committees, and your leadership and your boards. Because we need to know that there are voices in there reflecting our insights and what we know about our community. So again, I'm the president, the 124th of the NMA. I welcome you to join me in this fight. There is a lot of work to be done. As a Black physician in America, I feel like I'm in the fight of my life. Thank you. Did I do okay on time? I think I made it on the table. Okay, thank you. Am I taking questions? You wanna take two? I'll let you lead it. I'll take two.
So she wants to take a couple questions. Anybody?
I think they're ready to go when they have Bacardi.
You guys all ready for Bacardi? Is that what you have a question out from?
Ready for Bacardi.
There's a mic right there.
Thank you, Carol Magruder. I'm one of the co-chairs of the African American Tobacco Control Leadership Council. And I want everyone in this room to know that we are co-plaintiffs in suing the FDA to remove menthol and flavored tobacco from the market in the US. And so we have temporarily dismissed our lawsuit pending the rule that's supposed to be coming. It was supposed to be out in August. We are reactivating. We've been in contact with Dr. Mark Mitchell, and we look forward to the next steps as we move the legal battle forward on all fronts. So we appreciate the relationship that we have with you and look forward to moving forward. We'll see you in DC.
Absolutely. Thank you so much for those comments. Yes, Dr. Mitchell had me up late the other night working on menthol.
Anyone else? If you have a question, just make your way to the mic so that we can move right along.
Why the microphone gotta be taller than me?
Okay. You sound like you're a little thirsty. You ready for a sip?
Nicole Evans, I'm with the National Academy for State Health Policy, and we have a problem when it comes to Medicaid and clinicians that look like us. Because the reimbursement rates are what they are, our doctors don't want to take Medicaid beneficiaries. And then we have to send them to practices that aren't convenient for them to travel to, with staff that can't relate to their chronic conditions. So what is the NMA doing to encourage providers of color to move forward in a community concept so that they can serve our people? I'm sending the patients, but they don't have the doctors to see.
Where are you? What locale?
I'm in, my organization's based in DC, but I'm in Southampton Roads, not too far from Newport News, Virginia. And there was a road marathon, if you will, that the Department of Health and Human Services did. And the quality of care was abysmal in our communities, but you couldn't find a doctor that looked like us to stay there past residency or training or to put roots into the community because the reimbursement rates for Medicaid are so low. I understand that, you know, it's how you all make your livelihood, but something's got to give.
No, I agree with you. We, Secretary Becerra, we met with him. He came to our annual meeting right around August 1st. So that's a really layered and complicated issue. I brought it to HHS previously too. And one of the issues, many physicians no longer work for themselves. They're working with entities, they're employed. And so much of the payer acceptance is based. So if you're with a system, whether it's GW or whoever, the system may not. So I've been in a community a long time. So just because I'm the Black doctor, everybody tries to send me the Medicaid. They didn't know if I took it or not, right? Because while you say Black physicians, the Caucasians definitely don't take it, right? When I came out in practice, I joined my first job. I just thought you take care of people. That's all I thought about. You just take care of the people. And the white doctor said to me, well, if you want this nice office with this fancy furniture, you can't take Medicaid in here. And so it's a real thing, but that's another advocacy piece where we have to work on higher reimbursement. And that's a very complex issue because that's not a federal, that's a state budget, right? It's a state budget issue. They quickly turned me around when I tried to bring it up. But, you know, thinking about from a federal aspect, but it's a state issue. And then again, these states, you know, I'm in Texas, no Medicaid expansion. So it's even worse. And so it's very difficult to find providers of any color that will accept it. So I think we're coming to a stop where something's going to have to be done. But it's again, willing to join forces with you to continue to advocate for that.
Yeah, just a little history to underscore the complexity of the problem in terms of cancer in Blacks. In 1985, at the National Cancer Institute, when Dr. Claudia Paquet first pulled together, and that was the first time we really were looking at the data around cancer, Black-related cancer morbidity and mortality. And she pulled that data together for the first time in the publication, Cancer Minority Populations, I think it was the title. But she looked at that data at each stage, stage 1, stage 2, stage 3, stage. For every stage, Blacks had higher mortality rates. And what that indicates is that the problem, or at least the solution, is more than early detection. It has to do with something else that was not measured. And then you go forward a little bit with the National Cancer Institute. They had a major study looking at care in hospitals around cancer. But they didn't allow you to collect data on race. So there was this great initiative looking at care in hospital-based settings, but yet they really did not want to deal with the issue of racism. So they didn't collect data around race. Again, that's part of the problem, and part of the solution is having people at the table like ourselves, fighting for the right protocols, for the right policies that really enables us to advance our well-being.
I don't know if you were looking for a comment. I concur. Thank you. All right, you're welcome.
Dr. Yolanda, thank you so much. We appreciate you. Now that we've come to the end of the road. You know, I MC a lot of events for a lot of different companies, and this is my first time emceeing an event for us. And over the past couple of days, I had my eyes opened to the medical industry. I grew up in an age where my father, my grandfather, they didn't go to the doctor. You know, that was, you know, they just sat around and died. And I'm not like that. I get a hangnail, I'm at the doctor's office. Yeah. And my doctor recently retired, so so now I'm searching for a doctor, which is difficult. And being here this past couple of days, listening to the various speakers, listening to the insight, listening to the concerns, listening to all of you doing what you do to better our communities was very powerful and emotional, and it gave me hope. And I appreciate you for it, and I thank you, and I want you to just continue to do what you do because you are making a difference. And with that being said, I'd like to take a moment to introduce the board chair for the center, Anita Gaillard.
It's been a privilege to open this conference and to also just have a few words to close the conference. The first thing is thank you to everyone who is still in this room and here at the closing. We know we have a lot of work to do, and we appreciate you staying and hearing and participating and being a part of the program. And you all know this, but programs like this, the State of Black Health, the Center for Black Health and Equity, don't happen by chance. They happen because of strong, devoted, committed leadership, right? And that's what we want to do, just take a moment to let you know about the leadership of the Center for Black Health and Equity. You met the board members. We have people in the audience who've been around for a long time, people I can remember looking up to for many, many years. You know who you are. And I thank you personally for the work that I've been able to do primarily in tobacco control as a result of the work you're doing. But today, what I want to do is call Shantae Keith. Are you in the room? Is Shantae in the room? Come here. And Del Monte, come on. Come on. Come on. a program like this, and I mean, I do mean this week, but I mean every day. An organization like this doesn't happen by itself. It happens with leadership like Shante Keith and Del Monte Jefferson. So join me in saying thank you to them for this program and for their ongoing work that they do in making life better for us. And what we have, because we want this to be an enduring visual reminder of the work they do and our appreciation for the work they do. So we have some prints of a local artist that you can get framed and put, I know you have lots of stuff to get framed and put on your wall. And when you look at it, you think about how much we appreciate the work you're doing, the work you're going to continue to do, and the work that we're going to do along with them. Thank you, Del Monte. Thank you, Shante.
Thank you, Miss Anita. On behalf of Shante, we're just saying thank you. This was a lot of work, and what we're going to do about now is we're going to recognize where that work was, because folks, when somebody asked me here, they said, Del Monte, was it stressful planning this conference and putting this together? And my response was, it may have been stressful for somebody, but it wasn't stressful for me. So I want to bring up those folks that it may have been stressful for, and these are the employees of the center. Please come on up here. Come on up here. This is what makes it happen. All of the employees of the Center for Black Health and Equity, come on up on the stage. Come on up. Just make your way down, make your way down, make your way down. Lord, it's a lot of them. Where are these people come from? My goodness. Wow. Wow. It is a lot of folks, y'all. This is a lot of folks. All right. Come on. Come on. Come on. Yes, yes. Make your way on down. Keep on coming. Keep on coming. Keep on coming. Make your way on down. This is the Center for Black Health and Equity. These are our staff. They have varied positions. They got to build a bigger stage to accommodate these folks. Yes, yes. This is the Center for Black Health and Equity, y'all. These folks here, you know, they make it happen, and they pulled together and they did this conference and kept doing their regular jobs. And so they didn't like just stop and do a conference. They did it while still doing their regular jobs. There's about 34 of these folks up here that are in the center. And I appreciate and love every one of them for all the work that they have done and continue to do to make this thing work. We're not going to break the glass table, though, because we're not going to pay for glass tables. But yes, we couldn't do this. This would not have happened without them. Future conferences would not happen without them. Our work in communities that we do and the community partners, the Truth Be Told videos, those stories we tell wouldn't happen without them. So this is what makes it work. And everybody here is committed to health equity and being a part of changing the disparities in the state of Black health. And we're going to get it done. It may take some time, but we're going to keep on plugging at it, and it's going to happen and it's going to get done. Isn't this a beautiful, beautiful crew right here that's saving lives? That's saving lives. Now, the next folks I want to bring up to the stage, this ain't it, our board of directors, those members that are still here, because these are the folks that behind this. Now, y'all stay up here. Y'all, oh, you're going up front? Okay. Board of directors, come on up front. You want to see these other folks here that are making the decisions and that are supporting us and saying, yes, you can do this. No, you can't do that. This is our board of directors. And so this is the other part of the center and what makes this work. And so this is the village that we have behind the center from all across the United States. And these are the folks that are making it happen. We got our staff, we got our board of directors, we got everything that we need to save Black lives. And so we thank you guys for coming and participating with us here. We hope that you join us in 2025, where we take this event to Charlotte, North Carolina, which is home for us because our office is in Durham. So we're going home to Charlotte, North Carolina in 2025, and we hope you're able to join us there. Oh, photo over there, look over there. A wide lens. No, I'm sorry. And and wait now, because this has our consultants that have worked with us closely too. And Brittany, you still sitting down? I still see you there. And Tiffany, why are you sitting down? You're one of our consultants too that work with us. Y'all come up here. Now I said, come on up. Oh, he's down there taking pictures. Yes, our consultants are a big part of what we do and how we do it, and they're part of the work. So we got our staff, and we have so many, different contracts that we have to do. So we have to consult work and put it out there with these folks here. And so these are the folks that go out when there's no more room at the table for our staff. So look over here. All right. Now with that, Shantae, is there a poet or something that? All right. Huh? Monique King? And Mark is going, okay. All right. I do that? Okay. Monique King. Got it. You got it? Got it.
How about another round of applause for all these hardworking individuals that collectively got together and brought you a conference that is world class. And that being said, this type of event cannot just happen without sponsors, so I want to thank the sponsors who got behind this and helped the center put this together, especially the Robert Wood Johnson Foundation. And we want to thank you, the attendees, because without you, there's no conference. Without you, there's no hope. Without you, there's no brighter future for our people. So we want to thank you for coming out and supporting this event. And without further ado, please welcome to the stage Monique King.
Good evening, everyone. Can you hear me well? This is fantabulous. This is not the poem, it's just my feeling about being here and the joy that I have in seeing so many people working collectively, cooperatively, for something so valuable that impacts all of our lives and our futures. So thank you to Center for Black Health Equity and for each and every one of you who could be at the beach right now, but you're here. I appreciate you. Okay. I need your help with this spoken word piece. Would that be okay? Okay. All right. I had the pleasure of reading for a group of ladies at the Sip and Soiree. It was awesome. I learned a lot. I met some wonderful people. And what I told them is that anyone who steps up to a mic to perform anything may as well be stepping up stark naked in front of a bunch of strangers, because it's difficult to do what it is that anyone who is sharing themselves with you does. And so I'm asking that you meet or exceed my energy. I'm not going to ask you any rhetorical questions. If I say, how you doing? Then I'm really expecting you to say something. If I'm raising my voice, you can raise yours. Please don't feel like you have to wait for me to finish saying any word or any line. If you are moved, you do what you do when you're moved. Tap on the table, snap your fingers, clap your hands, say, oh, child, boo. Do whatever you do when you are moved. That's what I'm talking about. I need your energy to do what it is that I do, okay? So I'm going to give you a prompt, and this is going to be a collaborative piece. This is going to be a collab, okay? You only have 3 words. It's a long poem. I'll take care of the rest, okay? So your 3 words are, we need equity, okay? And here's your cue, okay? So when you see that, I need you to say, we need equity, but say it like you believe it because it's true, okay? Okay. You're in this world with me. Let me tell you how I would say it. We need equity. Because it's true. Oh, now you're feeling me. Okay. I don't sing. I'm a spoken word artist. And so I hope I don't crack any glasses with this first line. Oh, say, can you see? When it comes to the state of Black health, for them, for you, for me to exist, survive, and thrive financially, mentally, physically, your silence will not protect you. And mine might just cause me to explode into a folding chair wielding frenzy at the docks where my ancestors were sold by the dawn's early light. The wait has been too long from Puerto Rico to Mississippi. Goddamn, I'm sick and tired of being sick and tired. I'm sick and tired of being sick and tired. This Black woman is hangry, as in pissed off and starving for a justice no Snickers bar can cure the bitter taste of a collective apathy that all too often equals my tribe, my shared intersectionality, my fight to end erasure and disparity. I have all the words, just not the comprehension of how those who have been hobbled by the injustice of greed and power are expected to pull ourselves up by our bootstraps when we can barely stand on our damn feet, but spend hours on our knees clutching our rosaries and pearls, immobilized by audacity that gatekeeps my health, wellness, and dignity. I've waded in waters so long, my legs look like raisins in shining above. Lady Liberty went from brown to green, oxidized by hypocrisy. The illusion of the promise of equity taunts and reminds me how firmly rooted I am in a history that was, in a history that was, in a history that is and is and is and is denied, co-opted, muted by the removal of books and the excision of tongues that no longer speak indigenously, but has created and claimed new lexicons in languages like patois, Gullah Geechee, rap lyrics, and AAVE. You can try to deny it if you want to, but the truth is, I am the spice in your food. I'm the bop in your beat, baby. I'm the culture you steal, commercialize, and monetize. That's all me.
So cheers to us. May the red ink in your pen dry up while you stop cautioning me about using double negatives, baby. Child, boo, I ain't got no time for that madness. When in actuality, double negatives have become my life, the bane of my existence, much more than any mechanic of the language you forced me to learn and so eloquently speak. You see, I am an inventor. I am an innovator. I'm more than smart, linguistically, metaphorically, and literally. I'm intelligent, so I can clearly see how deep down that dream was never mine, never meant to include me, strangled by your stars, locked behind your bars, stripped and striped by your inhumanity. In our courts, in our schools, in our voting booths, in our clinics, in our streets, I wept like Mamie till tears ceased to flow. So I raged like Sandra, my rights desecrated, hanging in the balance, becoming so bland and tasteless, barely spoken of, about how I fought, how I fight like Angela, simultaneously most despised and most wanted. So I'll stop, I'll stomp, I'll beat my breast and storm like Audrey. Lord, this poem is a rant that's gone on too long, articulated for far too many centuries by far too few freedom fighters. You see, my freedom and the right to prosper is more expansive than any poem could ever capture. On the land worked by me, in the home of the slave. And the state of Black health depends on it. Thank you.
Let her hear, ladies and gentlemen. So that's it. Thank you so much for coming out and supporting, and we'll see you in 2025.